the founding president and the chairman of the board of directors of the American Association of Cardiologists of Indian origin. And we have co-directors of the symposium today, Dr. Hanumant Reddy, who is the president of the organization. We have Dr. Vishal Gupta, who is the president-elect of the association. Then we have Jags Kavalakunta, who is on the board of directors. And one person we are missing is Dr. One of the board of directors of the American Association of Cardiologists of Indian origin. And we have co-directors of the symposium today, Dr. Hanumant Reddy, who is the president of the organization. We have Dr. Vishal Gupta, who is the president-elect of the association. Then we have... And now I think I'm going to ask Dr. Hanumant Reddy to introduce our speakers.
Yeah, thank you, Dr. Nanda. Thank you very much. Appreciate everybody. I recognize Dr. Chowdhury and Jagadish Kalvakunta and Dr. Vishal Gupta. Thank you very much for joining us. A lot of people are going to join us very soon. And I thank everybody in the audience. This is a virtual educational meeting of AACIO. We couldn't do it in live the actual presentation, but even thank you for joining us. Today is going to be an exciting program. It won't be too long. Initially, we have a great speaker, Dr. Ravish Chowdhury. He's the actually director of the medical alignment for the medical affairs in AstraZeneca, and he has been a great supporter of AACIO. He supports AACIO independent of what we use. It's not related to any medication usage. He's a great believer in education, and you're going to hear his presentation. In the first presentation is from Ravish Chowdhury, and then after that, discussion and questions. And then next will be research abstract presentations by, I think, 3 fellows. It will be exciting presentations. And Dr. Sharma, welcome. If you unmute yourself. And we have after that, Dr. John Venditto. He's going to talk about clinical consideration in stroke and transient ischemic attack. Then, of course, word of thanks. Then the most exciting part of this program, Dr. Sharma would like it, and so he did it himself. Dr. Chakravarti is putting together Saregamapa winners, Bollywood playback singers Sanchita Bhattacharya and Bishak Jyoti. That's going to be an exciting program towards the end of this session. And we welcome Dr. Ravish Chowdhury. Again, thank you very much, Ravish, for being here and also getting ready for a presentation. Ravish, you ready?
Yes.
Ravish, we also Dr. Rakesh Sharma just joined. He is the vice president of our organization as well as the treasurer. So he is in charge of all the money. Most important person in our organization is Dr. Rakesh Sharma. Okay, go ahead. I'm sorry, Rakesh.
All right. So first of all, thank you so much for inviting me to speak. And, it's always, I'll share my slides. And if you can let me know that you can see my slides, can you see my slides?
Yes. Yes, I can see.
What we'll, let me just put it in presentation mode. So my name is Ravish Chowdhury, and I work as Director of Medical Affairs for AstraZeneca. And some of the things that, it's an honor to be involved with ASIO. And, we see how the good work that ASIO has been doing. And part of our aim today was to bring some very cutting edge information that we had. We had 2 indications, one in high-risk CAD, and that I'll talk about it a little bit more. I'll truncate my talk to some of the ACS and prior MI sections so that hopefully sometime later we can discuss a little bit and focus a little bit more about diabetes and high-risk CAD. And then we have a very interesting talk later on, which our head of thrombosis, John Venditto, will talk about, is in the area of stroke. I'm in presentation mode, so I can't see your faces. So if you have a question, just speak up. Normally I'd look for, expressions on the face, but I can't see it here. So in the next 40 or so minutes, I'll go over the 3 major areas that we are indicated, and I'll not touch stroke. And then mostly focus on diabetes and especially the role of platelets. I think that's a little bit underappreciated. So a little bit role of platelets, and then hopefully we'll have some time for discussion at the end as well. So as you already know that, in high-risk CAD without prior history, MI or stroke, so people who've never had MI or stroke, but have evidence of high-risk CAD, there's a 1 in 8 chance that they will experience an ischemic event in the next 4 years. Now that increases to 1 in 5 when they have an ACS event. And that we know that in almost 20% of people will have a subsequent ischemic event or death in the first year. And then once you get past the 1 year, the risk never really disappears. And if they looked at some of the studies here, we looked at, so if you survive the first year without having an event after an ACS, then in the next 1 to 3 years, you again have a 20% risk. So this is to talk about the entire spectrum of CAD before, during, and after, how the risk persists. So this is something that you guys are well familiar with. The risk factors that increase the probability of having a CV event across the full spectrum of CAD. So dyslipidemia, multivessel disease, smoking, hypertension, diabetes. I will focus a little bit more on diabetes and the diabetic platelet here, CKD and obesity. So this is an interesting study from the Swedeheart registry. So it's Swedish, and I'll show American data as well. So when you looked at 3-year risk for MACE, so the blue graph on top is people who had prior myocardial infarction, so already had a myocardial infarction, and you see the probability around 13.1%. But interestingly, if you take people with diabetes who have CAD but never had a prior myocardial infarction, their risk is 13% as well. So there was a time when we thought that diabetes, this clearly shows that if you have diabetes and CAD, the combination of diabetes and CAD, then it is like having a prior myocardial infarction. This is, again, data ongoing risk in US patients. The previous one was Swedish data. So this is in US patients. And here you see, again, the first year, the risk is about 18%. Second year is about 16%. And this is first year, which means that if you survived the first week, then your risk is 18%. If you survived the first, not just survived, but did not have an event in the entire first year, then the second year, the risk of a MACE event would be around 16%, and then about 14%. So suffice to say, even in US patients, the risk persists. This is looking at various, if you have how many risk factors. And so the risk factors are all listed below: age, multivessel disease, chronic CKD. So you see, as you get to 2 or 3 risk factors or greater than 3 risk factors, then you see that recurrent MI increases as the number of risk factors. So these are all intuitive, but good to see data again. So with this, what I really wanted to do is talk a little bit about the platelets, the role of platelets across the entire spectrum of CAD. Now, we know that previously we had talked about dyslipidemia, smoking, age, and all these are well recognized. I think the role of platelets is a little bit under recognized. So just starting off, we all know that platelets play a critical role in the thrombus formation, and actually they initiate the thrombus formation. So when there is a rupture, you'll see that platelets will adhere, they'll get activated, and they'll form the aggregate and form what is known as the platelet plug, and which kind of forms the template over which the rest of the thrombin generated clot forms. So platelets are the initial culprit in starting, and they do good work, except that when we have a situation where it occludes a vessel. So 3 major things that happen with platelets, which are worth mentioning, is in certain cases, especially when you have diabetes, type 2 diabetes, you have high platelet turnover and reactivity. So not only platelets are almost ready to go, and I'll show something that how they are almost on a short fuse, but the platelet turnover is high as well. Typically about 13% platelets will be replaced each day. And so in 7 days, all the platelets are gone. But because in type 2 diabetes, probably because the insult that it provides to the endothelium and other things, the platelet turnover is high. So we'll talk about that. There's endothelial dysfunction, and so endothelium releases. We'll discuss a little bit about that. Endothelium releases a lot of things like nitric oxide and PGI2, which keeps the platelets calm. And the endothelial dysfunction means, on one hand, you have platelets which are more reactive and ready to go. And then you have endothelium, which is not able to keep it calm. And then overall inflammation, which provides the entire environment. So let's start with the platelet dysfunction. So especially in type 2 diabetes, they are in a prothrombotic stage. And we know that the increased platelet turnover and reactivity, that is, we already know that that is well recognized in diabetes. There's increased intracellular calcium, upregulation of P2Y12 signaling, and P2Y12 is where ADP will come and sit and activate the platelet, among other pathways as well. So there is higher upregulation of P2Y12 signaling, increased oxidative stress, increased P-selectin and GP expression, and all these are basically making the platelet more reactive than they would normally be. And then deficient insulin action, that is impaired response to nitric oxide and PGI2. And nitric oxide and PGI2 are actually released by the endothelium. And therefore, when, they not, even if they are released, the platelets are deficient, they are not as reactive. So, it's like a little bit of an agitated state. So the other part of the story is the endothelial dysfunction, which is characteristic feature of patients with CAD and type 2 diabetes. So this entire thing, we're only talking about CAD and type 2 diabetes, not just people without type 2 diabetes. So we have increased production of tissue factor, decreased nitric oxide and PGI2 production. And this is what the endothelium will release to sort of keep the platelets calm. And then it's increased oxidative stress. So on one hand, the platelets are more reactive. Other hand, the endothelium is not releasing PGI2, nitric oxide, which kind of keeps the platelets in check. And then, of course, there is systemic inflammation, which contributes to the prothrombotic stage. And, it's well known, obesity, dyslipidemia, systemic inflammation, and all these other things. There's many other things that play a role. Some of them are listed there, which creates the overall prothrombotic environment. So with that, just recognizing that Brilinta is the drug that we are involved with for several years now, and we have a very wide range of studies that we have done. We started off with the one in the middle, over 18,000 patients in acute coronary syndrome. And then we had 45,000 patients who were studied in real world evidence as Sweetheart Registry. So we'll quickly go through this, not spend too much time on ACS. We've had known all the Brilinta activity in the last 10 years. Then quickly talk a little bit about the prior MI. So at the end of, in that ACS trial, the Plato trial, which I'll discuss quickly, if you see, when I show you the results, you'll see that at the end of 1 year, the curves were continuing to diverge. And so the question was, well, should we have gone longer beyond 1 year? And so that's why in history of prior MI, that is beyond 1 year, that Pegasus trial was studied, and I'll show the results as well. And then what we did, just like Star Wars, you do a prequel. So almost like that, we studied and said, well, what about people who've never had an MI, never had a stroke, but have diabetes and evidence of CAD, to see whether can ticagrelor plus aspirin actually prevent the first MI or stroke. So that's what we'll discuss. And the entire premise of these, what I will not go into, is the stroke trial that just read out recently, and we were indicated, and that John will talk about. So I'll focus on these three. So before that, I'm required to tell you what the indication of Brilinta is, and some legal slides that it is a proactive talk. So Brilinta in coronary artery disease without MI or stroke. So this is before people had their first MI or stroke, as long as they have coronary artery disease. So Brilinta is indicated to reduce the risk of first MI or stroke in patients with CAD at high risk for such events. While the use is not limited to this setting, the efficacy of Brilinta was established in a population with type 2 diabetes. So what is very interesting here is that Brilinta, the study that we did was with type 2 diabetes called THEMIS, which I'll show. But FDA kind of gave us a broader label saying type 2 diabetes and high-risk CAD. So as long as you have high-risk CAD, if there are other factors, which they'll leave it to your clinical judgment, which you feel that predispose them, then Brilinta is indicated there as well. Then, of course, our primary marquee study was in ACS. So Brilinta is indicated to reduce the risk of CV death MI and stroke in patients with ACS. And then a very unusual statement for at least the first 12 months following ACS, Brilinta, or it is superior to clopidogrel. And then Brilinta also reduces the risk of stent thrombosis in patients who have been stented for treatment of ACS. And then we have myocardial infarction, where I mentioned that, beyond history of myocardial infarction. So this is beyond 1 year, not in the ACS setting. So Brilinta is also indicated to reduce the risk of CV death, MI, and stroke in patients with a history of myocardial infarction. These are important safety information. And, warnings, bleeding risk. There's always, any antiplatelet, and especially potent ones, will always have bleeding risk. So Brilinta, like any other antiplatelet agent, can cause significant, sometimes fatal bleeding. Do not use Brilinta in patients with active pathological bleeding or history of ICH. Do not start Brilinta in patients undergoing urgent CABG. And if possible, manage bleeding without discontinuing Brilinta. And that is easier said than done. And but a group like this, you guys understand the risk versus benefit best. And stopping Brilinta may increase the risk of increases the risk of subsequent CV events. And there's one thing that we have known is that we always recommend, now it's well recognized in the US, that Brilinta aspirin dose is maintenance dose is less than 100. So you don't use 325 with Brilinta, you use maintenance. You can load with 325, but the maintenance dose is less than 100. Some contraindications: Brilinta, history of ICH, active pathological bleed, such as peptic ulcer and intracranial hemorrhage, and then hypersensitivity. And then the dosing in the management of ACS, Brilinta treatment with 180 milligrams loading dose. You load with 180 and then 90 milligrams twice daily. And in patients with CAD but no prior stroke or MI, administer 60 milligrams. So only in ACS setting, we have 90 milligrams BID. And of course, stroke later on when John will talk about it. But in before the first MI or stroke, to prevent, we have 60 milligrams. And in a history of prior myocardial infarction beyond 1 year, again, the dose is 60 milligrams. And use Brilinta with a daily maintenance dose of aspirin 75 milligrams. So very quickly, I'll talk a little bit more about how Brilinta acts, how it's a little bit different from Plavix per se. And, well, I'll not go into Plavix mechanism, but I'll talk a little bit about, at this point in time, just talk a little bit about how Brilinta acts. So if you see that, what you see on the top there is the P2Y12 receptor, which is kind of sticking out, and ADP, which is circulating, binds to the P2Y12 receptor. And once it binds to the P2Y12 receptor, then the signal transduction, and that activates the platelet. I mean, that also happens with aspirin through a different mechanism, but this is the P2Y12 mechanism. And what Brilinta does is Brilinta goes and binds reversibly to a site, not where ADP sits, at a site that is different from where ADP sits. And so ADP can come and sit, but that prevents the signal transduction, and so the platelet does not become active. Now, the other part is very important to keep in mind that, type 2 diabetes and a lot of other, comorbid conditions, the platelet turnover increases. So typically body will produce about 10 to 13%, 13% platelets are replenished daily. And that's why, when you give certain drugs like aspirin and, you are looking at 7 days, the efficacy kind of lasts 7 days. They are active there, but, they come and bind, but the majority of the effect comes from, they bind to the platelet, to the P2Y, to the receptor, and literally make the platelet inactive. And what happens is then the new platelets have to come in for the functionality of the platelets to be reversed. Whereas in Brilinta, what happens is it's always there. So it does not need metabolism. It's always there. You're giving in a BID dosage. So it doesn't matter you have 13% or much higher rates of platelets coming in. Brilinta will always bind to the platelets and keep them in check. So this is a really important aspect that, in diabetes and other places, not only platelets are more reactive and the environment is more thrombogenic, but the turnover, the rate at which the body is producing platelets, and especially we talk about the juvenile platelets or reticulated platelets. These are half-formed platelets that are dumped into the bloodstream because the body is churning them at a higher rate. And that's where Brilinta is always there. So it doesn't matter what is the rate at which the platelets are churned out, Brilinta will always inhibit. So you have a more consistent action. So with that, let me jump into the studies. Like I said, I'll try and go fast with the ACS and prior MI studies, and hopefully some other day we'll go a little bit more into these acute coronary syndrome and history of prior MI, because I want to spend a little bit time looking at the Themis trial where people did without a history of prior MI or stroke. So this was our Plato trial design. It was an all-comers trial. People came in and they were randomized to ticagrelor or clopidogrel, and everybody on aspirin without knowing the coronary anatomy. So that's a big thing, big step to take, that, you say, well, some people obviously will go 10% end up with CABG. So they say, well, we are not gonna know the coronary anatomy, but we'll still go and randomize and put them on ticagrelor and 50% on clopidogrel and 6 to 12 months exposure. And they were looking at CV death, MI or stroke as the primary endpoint. And then there's a bunch of secondary endpoints, and they were looking at Plato total major bleeding, that Plato defined bleeding. So this is the results. And as you can see on the left panel, the Kaplan-Meier curve, time to first occurrence of prior, so CV death, MI or stroke, there's a significant reduction from 11.7 to 9.8. So this has been well established, that we already know. What is more interesting is when you look at death, that is always more difficult to attain. And so in the death, you see on the right, 5.1 to 4.0, significant reduction in death. So you're looking at, if you treat 54 patients with Brilinta instead of the gold standard at that time was clopidogrel, then you reduce 1 CV death, MI or stroke. And on the death side, if you treat every 91 people you treat with Brilinta instead of clopidogrel, then you reduce 1 CV death. And then when you break it down, you see that mostly this was driven by CV death, MI and MI. Stroke was not statistically significant in this group. When we say, well, similar to clopidogrel. But you see, like I showed earlier, and then definite strength thrombosis, that was reduced as well. So that was significant as well. Now, all of these drugs, especially when you're giving 2 antiplatelet, they'll come with bleeding consequences. And, the Plato major and minor bleeding was higher with Brilinta 7.7 versus 6.2. But the good part was that the fatal or life-threatening bleedings were not statistically significant. And then when you look at fatal bleed, I mean, numerically, they were very, very comparable. ICH, fairly comparable, low events. And then CABG, now what they also did was they said, well, let's break it down to CABG-related bleeding and non-CABG-related bleeding. And CABG-related bleeding, what you see is it was numerically very similar. And you'd expect a more potent agent to cause more CABG-related bleeding. But as you see in 626 in Brilinta and 666 in clopidogrel, so fairly comparable for CABG. But when you looked at non-CABG-related bleeding, that was higher with Brilinta. All right, so this was our ACS trial. Next, what we'll do is go into, actually, let me go back to one slide to just make a point. So if you see here, as you can see, kind of eyeball, and you see that this is 1 year trial, and you see at the end of 1 year, the curves continue to diverge. And so the question was asked was, well, should we have gone beyond 360 days? So then that's the time, then after Plato, the decision was made to discuss about the Pegasus trial, which was basically on available data. We looked at some of the available data, and the discussion around that time was to say, well, let's look at people who have a history of MI, not everybody with ACS, but people who have a history of MI. And that's where there was no clopidogrel. So we said the discussion was that, we compare ticagrelor to placebo on a base of aspirin. So tica plus aspirin versus aspirin alone. So something to keep in mind, that you have 2 antiplatelets versus 1 now. So we expect some efficacy, but 2 antiplatelets, you expect some bleeds as well. So this was everybody, the inclusion was one prior MI 1 to 3 years before randomization, because we had already studied in the first 1 year in ACS and showed it superior to clopidogrel. Therefore, here they said you have to have an MI, but at least 1 year or more than 1 to 3 years. That's the group, and some additional risk factors. So it's listed there: age, diabetes. So this was a little bit enriched population, and it was ticagrelor versus placebo. So when they started, they were looking at both ticagrelor 60 and 90. And then subsequently, our label only says 60 because of the results from we saw that 60 was actually not that inferior, but had some better safety outcomes. So this is the baseline, 94% on lipid therapy, prior P2Y12, prior P2Y12 inhibitor, 89%. So these were people who had been treated in ACS setting with P2Y12, and then stents, multivessel disease. So that's all laid out in the baseline characteristics. So this is the primary efficacy endpoint of Pegasus, where you see a significant reduction from 9.0 to 7.8. And you're looking at a number needed to treat of about 79. And then when you look at bleeding, there was more bleeding. And remember, it's 2 antiplatelets versus 1, and a more potent antiplatelet to begin with. So you're looking at TIMI. So the bleeding definition they used here was TIMI. And the TIMI major bleeding was 115, so 8 per 1,000 patient years versus 3 on the placebo group. And then fatal was similar, ICH was kind of similar. TIMI major or minor was 11 versus 5. So when you combined, TIMI major and minor was higher. And then and the other part is diabetes increased. So we looked at the diabetes subgroup and said, well, what about people who had diabetes in the Pegasus subgroup? And we clearly saw that diabetes increases the risk of recurrent CV events in patients with prior MI. So this was very exciting. And we said, well, there is a 11.76 to 7.8 reduction with ticagrelor. And therefore, so this is looking at those with diabetes and those without diabetes. So if you had diabetes, obviously your risk, it shows that even in this population, you have more events. So with that, let's come to the third trial. And I apologize if I'm dumping too much data, but hopefully just a recap that we did. The first trial I showed you was in acute coronary syndrome, showing ticagrelor superior to clopidogrel and on a base of aspirin in acute coronary syndrome the first year. The second one I showed was beyond 1 year, 1 to 3 years with a history of MI, and that's the Pegasus trial. And so now we'll go, before people had their first MI or strokes. It's a risky trial to do, and especially antiplatelet agents, which can cause bleed, but the idea was can be extended. So the study was designed in such a way that they're looking to collect about 1385 events, and so roughly 19,220. And this is the other part I wanted to mention as well, is these are large trials. These are not small trials, not few hundred, few thousand. These are large trials, each one of them 18,000, 19,000 patients. So it's good commitment to science. And patients were, remember here, we were not looking at everybody with diabetes, but patients had to have underlying CAD plus type 2 diabetes. And the key inclusion criteria was, so CAD was defined as either you had a history of PCI or CABG, or 50% lumen stenosis. So that's, and then age was greater than 50 with type 2 diabetes, so all of them. So this is what defined, you have to underline CAD and diabetes. And then you excluded history of previous MI or stroke, because, obviously we have already studied that. And planned revascularization. If you were planning to revascularize them, that was excluded. And the primary efficacy endpoint was composite of CV death, MI, or stroke at 36 months. And of course, here again, we used TIMI major bleeding. So I'll not go into the inclusion-exclusion criteria just to save some time and show less data. But these are, again, the select baseline characteristics. So you're looking at type 2 diabetes, hypertension, 100%, of course, had to have type 2 diabetes. hypertension, dyslipidemia, multivessel disease, obesity, and current smoking, all that is listed there. So this is the primary efficacy endpoint. And what you see here is that the curves separated after, say, about 12, 15 months. And the study ended at 36 months. So you see 7.6% to 6.9%. But they continue. Some people were enrolled earlier. So some people were followed up to 54%. So you see a hazard ratio of about a 10% reduction. Now remember, these are people who've never had a MI or stroke. So this is even before the first MI or stroke. So you see a 10% reduction, and that is statistically significant. And then when you break it down, so you're looking at time to first CV event, time to event. So you see about 24 events per 1,000 patient years in the ticagrelor arm, and 27 patients per 1,000 patient years in the placebo arm, and CV death. So this was statistically significant, but we follow a hierarchical analysis. So what we say is we'll first look at the primary outcome. If that is positive, then we'll look at the next outcome, and then the next outcome and next outcome. If at any given point in time, the next outcome, which is kind of decided by some people, who are running the trial, if that is not statistically significant, then we will treat everything else as hypothesis generating only. So interestingly, we saw that CV death was not statistically significant, and therefore, even though myocardial infarction from statistics point of view and stroke from statistics point of view was statistically significant, it's treated as hypothesis generating only. But it's good to see the trend, because I think later on we'll discuss the stroke sub-study in stroke itself. And then, of course, the CV secondary endpoint, CV death, MI, ischemic stroke, all-cause death. Now, we cannot discuss a trial like this without safety outcomes. So TIMI major bleeding was higher, 206 versus 100. So 9 versus 4 in terms of 1,000 patient years. Other safety endpoints, we are looking at TIMI major or minor bleed, about 12. These are higher. So you're looking at 1 fatal bleed versus 0, ICH 3 versus 2, sort of higher in terms of 1,000 patient years. Now, one thing I wanted to also mention is that 58% of people in this trial had prior PCI. Remember, the inclusion criteria included history of PCI. So 58% of people had a history of prior PCI. So they decided to look at those people with a history of PCI. And again, none of them had prior MI or stroke. All of them 100% had diabetes. So this is, again, looking at that sub-study. So you're looking at 19,220 patients, and you either give TICA or placebo. And this is the Themis PCI subgroup, which is 11,154 people had pre-specified. This is the pre-specified analysis of people with prior PCI. And it's Brilinta versus placebo, and then the drug-eluting BMS and no stent is listed there. So very interestingly, here you see that it was a little bit enriched population, and results were a little bit better as well. So Themis history of prior PCI, you see 15% reduction as opposed to 10 that we saw earlier. 15% reduction in the cumulative event of CV death, MI, or stroke. And then what you see on the right is the breakdown. So Themis overall, you're seeing 10.1 versus 10.8, composite of CV death, MI, or stroke. And then history of PCI, you're seeing 9.3 versus 11. So a little bit 15% reduction. And when you break it down, when you see no history of PCI, it is a little bit blunted. So it does appear that people who have a history of PCI benefit a little bit more. And the average follow was 39.9 months. So Themis PCI primary and secondary outcomes, when we break it down, then you see the Themis overall, you see that it's on the left, favoring ticagrelor on the top there. And Themis PCI, when you look at PCI group, then you see it was a little bit more pronounced in people who had PCI versus history of PCI versus people who did not have a history of PCI. And then when you break it down, it's listed there, CV death, all-cause mortality, MI and stroke. Bleeding in this group, when you look at TIMI major bleeding, you're looking at 2.2 versus 1, so higher. I mean, history of PCI, you say 2.0 versus 1, no history of, so a little bit, bleeding is a little bit less compared to people without a history of PCI in the Themis study. So, with that, I think I have kind of come to the end of my presentation. Hopefully it was not too much of a data dump, and I can quickly summarize. So patients with atherosclerotic cardiovascular disease are at long-term risk of CV events at any point along the spectrum of cardiovascular disease. So we talked about high-risk CAD without prior MI or stroke. You're seeing 1 in 5 have an event. ACS 1 in 8 had an event. ACS is 1 in 5 have a risk of subsequent event, and history of prior MI stroke again 1 in 8. Underlying high-risk comorbidities such as type 2 diabetes further increase the risk of CV events in patients across the entire spectrum of CAD. So that we know that it's the CAD which is provides a risk, and when you have diabetes, like I mentioned earlier, when you have platelets which are more reactive, more ready to degranulate and become active, and that is because of, we see in type 2 diabetes, we see that the endothelium is a little bit more, it's not releasing PGI2 and nitric oxide to keep the platelets calm as well, and then the general prothrombotic environment. So that gets further complicated if you have CAD. CAD complicated by diabetes is associated with a number of abnormalities. That's what I just discussed, prothrombotic disease state and platelet function. The platelet plays an essential role in the pathophysiology of atherothrombotic CAD. Antiplatelet therapy plays an essential role in reducing CV events. So that's what and Brilinta in combination with ASA has proven efficacy across the spectrum of CAD. So before the first MIR stroke in high-risk CAD, during the ACS event, and then beyond in the post-MI. So some additional things to wrap up about Brilinta. Dyspnea was reported more frequently with Brilinta than in patients treated with control agents. And dyspnea from Brilinta often is self-limiting. So if the patient powers through that, majority of the times it's self-limiting. And we have not seen that dyspnea actually causes any additional harm or lack of efficacy. But unless the patient refuses to take the drug, then that's somewhere you might want to switch. Discontinuation of Brilinta will increase the risk of MI, stroke, and death. When possible, interrupt therapy with Brilinta for 5 days prior to surgery. That has a major risk of bleeding. If Brilinta must be temporarily discontinued, restart as soon as possible. Ticagrelor can cause ventricular pauses, bradyarrhythmias, including AV block that have been reported in post-marketing setting. And this is something that you'll see more 3-second pauses, but no increase in 5-second pauses. Avoid use of Brilinta in patients with severe hepatic impairment, and this is a new thing that's been added as well in patients with heparin-induced thrombocytopenia. False negative results for HIT-related platelet function have been reported, including heparin-induced platelet aggregation assay. So that in that case, Brilinta is expected to not impact the P4 antibody testing for HIT. And most common adverse reaction associated was bleeding and dyspnea. Some other things to keep in mind is, CYP3A4 inhibitors and inducers. So Brilinta goes through the same mechanism, so there is some interactions. Aspirin, like I mentioned, you use low dose of aspirin with Brilinta. Opioids, it reduces the absorption, like a lot of other drugs will reduce the absorption, especially if we were talking about STEMI earlier. And so that's something to keep in mind. Simvalova and digoxin, lactation and breastfeeding is not indicated. So with that, I will stop here. Hopefully I kept in time and it was not too much of a data dump. I apologize, there's a lot of information, but I'll stop and see if there are questions.
Well, thank you very much, Ravish. You did a wonderful job. Actually, you covered a huge amount of information in a short period of time. I don't know how you did that. Pathophysiology, all spectrums of clinical conditions where Brilinta has been useful, but there are also side effects on how to avoid usage of Brilinta in some high-risk populations. Mainly the bleeding part also you covered very well. Thank you very much for a great job. Dr. Naveen, Rakesh, Jagadeshwar, and Vishal, any questions, comments?
Rakesh Sharma from Clearwater, Florida.
How are you doing?
Excellent presentation. Very good. I really enjoyed it. I really liked your presentation of THEMIS trial. Two questions for you. Number one, in the THEMIS trial, the history of PCI, was there a remote history of PCI, like more than 3 years, or what a recent history of PCI?
No, so THEMIS was basically, when they were recruiting. So I mean, they did not decide how long, because that was in Pegasus. When you looked at 1 to 3 years, you didn't want MI. But here, when they were recruiting, it didn't matter. If you had a history of PCI, as long as you did not have MI or stroke, right? Okay. I mean, so you did not have MI or stroke, but if you had history of PCI, and partly I feel that the PCI must have been done because of the underlying CAD. So it was not defined whether you had to have in the last 1 or 3 years. What was defined was that if you had diabetes, you had to have diabetes for at least 6 months. Right. So that hopefully that answers your question.
Right. No, that's an excellent trial. It does prove the story of a strong, potent, predictable Brilinta, which works very well in a state wherever there's a prothrombotic hyperplatelet situation, such as the patient you enrolled in THEMIS trial. So I think that was a very good trial. One more question, and then I will let Dr. Let me ask you this. I am almost 99% Brilinta user in my patients. Yeah. As I was a national Brilinta speaker, as you know, for a long time.
But you should have given the stock then.
The question I often think about is, if I have finished the PCI and after 3 hours there is a intracranial hemorrhage, right? So what are our options based on the pathophysiology presented? The Brilinta is hanging around, ADP receptor is still there. What is the possibilities we can do in addition to giving, even if you gave new platelets, the Brilinta hanging around there probably still going to affect those platelets?
Yeah, and that is a challenge. I mean, that has been a challenge, and there are some other therapies, because this is a proactive discussion. I can't really go into that, and that's not indicated. So maybe one-off, we can discuss it separately as well. Are you familiar? Very exciting, some work Deepak Bhatt has been involved with. But I would say that right now, I mean, ICH. So the biggest thing that we can say is, if you look at 18,000 patients in Play-Doh, the incidence of ICH compared to clopidogrel was low, right? I mean, but Brilinta is a more potent agent. So one advantage with Brilinta is that it dissociates and the platelet becomes active again, right? And so that's why it starts at a much higher rate. But the bleeding, if you see, they say that you have to stop, just like clopidogrel, that 5 days. But the challenge is that you are exactly right. The challenge is that if you give more platelets, Brilinta is there and it'll inhibit. So the first thing to do is to stop the Brilinta right away. Now, one advantage of that is that when you stop the Brilinta right away, there will be some Brilinta that will be cleaved off the receptors, P2 vital receptors, and the platelets will become active again. So some of them will become active again. So that might be one of the reasons why you're seeing bleeding, which is kind of similar to Plavix, which is a little less potent. But in Plavix, you can overwhelm the system by giving more platelets. In Brilinta, I mean, that is you cannot basically give more platelets, and we don't have any study to show that. So I think the best way right now is to stop the Brilinta. It has a quick offset. I did not show the onset offset. You probably are familiar. I did not show that. So it has a quicker offset. But the only thing I'll say is that at this point in time, the best way to look at is Plato, where you did not know the coronary anatomy, and overall we had lower incidence. But you're exactly right that you cannot. Platelets will probably have less effect to reverse it.
Thank you for that. Thank you.
Of course.
Naveen, you have any questions?
Any other questions? Jags, have any questions, or Hanumant?
Yeah, I have actually
Vishal?
questions.
Sure, after Hanuman.
Nobody. Oh, Vishal, go ahead, Vishal.
So,
you are a bigger
hey,
user.
excellent presentation. Thank you. That was a good overview of platelet treatments. Question is, what's next for Brilinta? Are you guys looking at valvular heart disease and left atrial appendage exclusion, especially post procedure? As an example, when we do Watchman or we put an amplats in, we still send patients back on anticoagulation. In my opinion, once you've put a device in, the role of anticoagulation literally disappears because there is significant, blood movement in those areas, and areas which are deep inside the appendage are excluded already. So you think you're going to be looking into post Watchman, post valves, post mitral clips?
So if I had done this talk 6-7 years ago and you had asked this question, then I would go back and say, look, we should be looking at all these things. Unfortunately, Brilinta is like kind of, so the choices they made was ACS prior MI, Themis history, never had an event. They looked at PAD only, they looked at stroke, and the second trial, they did 2 trials with stroke. So the big trials were all centered around that. There was consideration around these trials, and we kind of beyond the small studies that we did, so we really don't have data in that area. And the challenge is that where Brilinta is right now, when you get to late growth, early major, there's a whole business side which you have to convince to do more trials. So at this point in time, we don't have any specific data that I can discuss in a proactive setting. One-on-one, we can show you some of the data that we have, but we are not indicated. And right now, I doubt, unless something dramatic comes up, I doubt that. When those are really good areas to discuss. It's just that the business side will will overwhelm, and it'll be harder to convince to do a big trial, right? These are hundreds of millions of dollars to do a big trial. So unfortunately, Dr. Gupta, we probably, I'll just be honest, I doubt we will, but when it becomes generic, then Dr. Salim Yusuf did a polyp study presented, right? So there's lots of possibilities. But I'll stop there.
Thank you.
You're welcome.
I think I saw some questions from Dr. Aditya as well as from Dr. Roy Chaudhary. Could you read those questions? I couldn't read them thoroughly. Hanuman, did you see those questions?
No, I didn't. But actually, can you flash it again, or you can
read?
I see that.
Questions?
The chat.
Do we need to adjust the dose of ticagrelor in the patients with thrombocytopenia, but still with a high risk for cardiovascular death, or is there a clear cutoff for platelet count to use it? That was the first question.
Okay, so I'll have to get back to you on that. I have not seen any cutoff for thrombocytopenia, but what I'll do is, before I answer that, let me get back to you and see what data that we have, especially related to thrombocytopenia. And but all the literature that we have, all the indication that we have, I have not seen a cutoff. But that is, you have to always be careful. So I'll let me go back, and Dr. Roy Chaudhary, where, if you don't mind, I can take your details, and either I or our MSL can get back to you, and we'll get you the data around the cutoff.
Revision clinical practice, we have never done it, of course. Modifying the dose of Brilinta, whether there's a thrombocytopenia, of course, you got to be careful.
Yeah, and that's why, I just want to make sure that, if we have some data, so I have not seen, there's no guidance, right? That's from a FDA label point of view, there is no guidance that, or a cutoff, but I do want to follow up and see what data we have, anything specific information. The other one is recent data published in Lancet and presentation released at AHA meeting, Alpheus. So Alpheus was presented at, it was day 1 of AHA. Did not show any increase in benefit of TICA over CLOPI. Any comments? So this is a good question. And the reason why I can answer this is within the preview of acute coronary syndrome. So in Alpheus, they were looking at 48-hour they were looking at 48 hours, and they were seeing that within 48 hours, was there any benefit of Brilinta or clopidogrel in elective PCI. So what the general consensus, and I'm sure you probably saw the Alpheus presentation at AHA as well, the general consensus was that there is too much noise, right? And when you're looking at damage, it could be from the stenting procedure or the inflation of the balloon itself. So there was too much noise. So it was not looking at they looked at 30 days and it was not powered. So right now, Brilinta is actually not indicated in elective stents. So this trial is not looking at ACS or prior MI, or that was not where we're looking. They're just looking at, clopidogrel is the drug that is used in that case. And so Alpheus, I mean, general consensus that we saw when people were talking about it, I mean, that was the general consensus that, hopefully you heard the commentary as well. It's very difficult to say, well, if that 48-hour, troponin increases and all that was not because of the procedure itself, right? So those were difficult to tease out. So it's a small trial, two countries, I think France and I can't remember which other country. So, that's all I can comment in terms of it's not in an area where that's where we are not indicated. So I'll just leave it at that, and we can't comment one way or the other. I mean, ticagrelor is not indicated for elective stenting.
Any other questions for Dr. Ravish? I think that was really a great presentation. Congratulations, and thanks very much for that. And I think we can move on to the next part of the program. And the next part of the program is going to be Young Investigator Awards. And we have three of them here, should be three of them. One is Dr. Venkata Pajuru. Another one is Dr. Vardhaman. And Vardhaman, actually Jain, and also Amit Khera. Is Venkata Pajuru here?
Yes, Dr.
You're here? Okay.
Yeah.
Venkata Pajuru got the, congratulations, Venkata. You got the Dr. Krishna Ramaswamy Award, and in the section on interventional and EP, and your topic is going to be in-hospital outcomes of percutaneous coronary intervention, PCI, in non-Agenarians, an updated systematic review and meta-analysis. We've got about 5 minutes or 6 minutes to give your talk.
Thanks, Ratnanda. I'll share my screen now.
Okay.
Good morning, everyone. I hope everyone can hear me well. As Dr. Nanda was telling, my name is Venkat. I'm one of the final year internal medicine residents at Creighton University, School of Medicine at Omaha, Nebraska. Today, I'm going to talk about my research project on in-hospital outcomes of PCI in non-Agenarians. It's an updated systematic review and meta-analysis. I'm going to give a brief introduction and background of my topic. So non-Agenarians are classically referred to people aged more than 90 years. As you see here, this is the figure that I obtained from United Nations World Population Prospects, and it showed age 90 and more are the most fast growing population subset. And I was looking into few countries to get my references, and in the United States, back in 2010, there were 1.9 million non-Agenarians, and they projected that their numbers will quadruple by 2050. And in Australia, the fastest senior group are 90 plus year age group. So the previous meta-analysis done on this topic included only 7 studies with 500 patients, which showed PCI is an acceptable strategy. But since then, there were many studies came up showing what are the benefits and risks associated with PCI. And as age increases in this age group, we know prevalence of coronary artery disease is expected to increase in the same fashion. So there is still a fair amount of uncertainty exists pertaining to management of acute coronary syndrome and stable angina in these patients. Should we do PCI given the age and risk factors, or just we do medical management? That's what motivated me to do this project. So we systematically analyzed all the studies as I shown in this PRISMA chart using both the PRISMA guidelines and the MOOS guidelines. The inclusion criteria for our project was any study that included PCI in more than 90-year-old patient subset. And we included all the PCI, any studies that from inception till December 2019. And we wanted to make sure there is in-hospital mortality available for all our studies. So as you see there, we found 33 studies with 18,835 patients. And out of them, 70.5% are presented with ACS, either with the STEMI or NSTEMI, and 29.5% patient had stable angina. And out of these 33 studies, 28 of them had in-hospital mortality and included in the analysis. Cardiogenic shock at presentation was presented in 10 studies, and 18 studies had data on in-hospital stroke, and 11 studies had data on bleeding complications. So the forest plot, the figure 1 on the left side showing the forest plot of in-hospital mortality following PCI, it's close to 12% with the confidence interval between 0.09 and 0.06. And on the right side, the forest plot showed the cardiogenic shock at presentation was almost 4% with the. So this is the figure 3 on the left side showing the in-hospital stroke. We found very less in-hospital stroke of almost only 2% with confidence interval 0.01 to 0.04. And the last figure on the right side is the forest plot showing in-hospital bleeding complications, which was around 1%. So going through all the forest plot and the complications, so we think that this contemporary data on the PCI non-engineering showing acceptable in-hospital mortality and periprocedural complications. One of my recent studies on STEMI non-engineerians in the United States, we had 2 cohorts, PCI versus medical management, again showed significant benefit with primary PCI compared to medical management. So I want to conclude that advanced age alone cannot be considered as a barrier to invasive intervention as we continue to see age population presenting with ACS. So I think PCI can be offered to non-engineerians, either acute coronary syndrome or stable angina, after careful risk stratification with discussion benefit and risk ratio.
Okay, that's great. Any questions from any of our panelists or from the audience? Any questions for this? Is really an excellent presentation, and your abstract was selected as the best one in this category. So you'll be getting a check of $1,000 from our treasurer, Dr. Rakesh Sharma, also, and from Dr. Hanumant Reddy, and also I will be sending you sort of a certificate on the internet, which you can print on photograph paper and frame it as a plaque. Any questions for?
Congratulations, Venkata. Great job. Actually, what I do is I never discriminate. Actually, people are getting older, people are living longer, so we would do intervention 90 or 100. We don't look at the age. How fit the patient is. Risk stratification is important, like you mentioned. Good study. Very good study.
Thanks, Dr. Reddy.
I think that the only thing I question is did you take into account something like frailty there? I mean, you can have a person who is 90-year-old who's very active and another who is 80-year-old and very frail.
Yeah.
Any comments on that?
In all of the studies, they didn't really mention the frailty, but with the NIS study that we did in STEMI non-engineerians, we were able to include the frailty score. In that, even the frailty score was considerable for us to do the STEMI, but some patients who were presented with cardiogenic shock and who had CABG, they had more frailty compared to other people. That's what we found on that study.
Mm-hmm. I was also thinking in terms of not only physical frailty, but also mental frailty, like Alzheimer disease, or any comments on that also, Venkata?
Not in this meta-analysis, but the one that I did in STEMI in US, in that the dementia patients underwent significantly less primary PCI compared to medical management. And even though there is significant mortality benefit with dementia, we think that maybe family or caregiver role could have caused the medical decision making at that time. That's what we are trying to work on, to see how many people are actually doing ACP, like advanced care directives, and how many of them, with the dementia, they didn't really want to have any invasive interventions. That's something that's a really area to explore.
Mm-hmm. Well, very good study. Really enjoyed it very much, and you deserve the prize from us. It's always our practice in this association to actually encourage young investigators, from the Indian subcontinent. So really, we are very happy you'll be here. On a personal level, just give my regards to I know some of the people in your cardiology division. I've given some ground round there a while ago, and Dr. For example, Gillet Venkata, Mahesh Ala, give my regards, and Smear also. We have collaborated on some research with them. Thank you very much. Thank you very much.
Thanks,
Thank you.
It was my honor. Thank you all.
Yeah. The next presentation we have is going to be by Dr. Vardhaman Jain, and he is going to be talking on actually, let me read it out to you. He's going to be talking on, he gets the Dr. Madhukar Deshmukh Award. The Venkata Pajuru got the Dr. Krishna Ramaswamy Award. Dr. Ramaswamy was one of our past presidents who passed away, and we have another award for Dr. Madhukar Deshmukh. Actually, he was from Bombay. Actually, he was my mentor also. He also passed away a while ago, and this is going to be in the section on preventive and clinical and imaging cardiology, and the abstract which got the maximum score was by Dr. Vardhaman Jain. He's going to talk on coronary microvascular dysfunction in patients with chronic kidney disease, systemic review, and meta-analysis. Dr. Jain, are you on the line?
Yes, thank you, Dr. Nanda.
Yeah, okay, thank you.
Everyone, I'm Vardhaman. I'm one of the second-year residents in Cleveland Clinic in Ohio. So I worked on this project with Dr. Bajaj, and Dr. Nanda also really helped out with his collaboration on this one. So there's a lot of interest growing as to why chronic kidney disease patients have elevated cardiovascular risk, and some of the initial studies thought that because they have other risk factors that confound the outcomes. But then since 2008, I think there were a lot of studies that showed that if you adjust for everything, only presence of chronic kidney disease can cause elevated cardiovascular risk. And then since 2010 and 12, since more advanced imaging has evolved, people saw that there might be coronary microvascular dysfunction because of chronically depressed GFR and uremia that might be causing like capillary rarefaction, endothelial changes, and all those changes over years build up and predispose to elevated cardiac mortality. So till date, we couldn't find anything that could summarize these findings and could better, kind of guide the transition from bad kidneys to bad heart. So that was primarily why we conducted this review. So and we have no conflicts of interest to disclose pertaining to this study. So, like I said, patients with chronic kidney disease have elevated cardiovascular risk, morbidity, and mortality, and it's thought that impaired coronary flow reserve is probably the underlying mechanism. So we carried out a systematic event meta-analysis of available literature, mostly observational, that was looking at coronary flow reserve and microvascular dysfunction in patients with CKD. So we searched available data sets, Medline, Embase, Web of Science, and Cochrane to find studies that talked about CFR and CKD. And we performed a meta-analysis and a meta-regression after adjusting for all the confounders that might also elevate someone's cardiovascular risk. And we also sought to see if there was a dose-response relationship between the impairment in CFR and the impairment in GFR, sort of to quantify if GFR can be used as a surrogate for cardiovascular risk. So we found 22 studies that met inclusion criteria. And just as a background, a lot of patients would have pre-existing coronary artery disease of the large vessels like left main, right coronary, which might also affect coronary microvascular dysfunction. To eliminate the confounding effect of that, we only included studies that reported on patients both with pre-existing and no pre-existing coronary artery disease, and we found 14 of those. So we found that the CFR was significantly impaired in patients with and without CKD, 2.1 is to 2.7, with a standardized mean difference of 0.84. And the three main study modalities that most of these studies looked into were of measuring CFR was transthoracic echo, coronary wire, and nuclear PET stress. So we adjusted for those: age, pre-existing coronary artery disease, and obesity, hyperlipidemia, and diabetes, and hypertension. And we still found that this association was significant. And we further found that this was a dose-response relationship did exist between impaired CFR and impaired GFR. And so to better sort of think this is a potential scope for an evolving therapeutic target, that if coronary flow reserve and improving capillary rarefaction can be a therapeutic target, that might help us address this this factor for coronary artery disease, and especially given CKD is so common in the population. And the forest plot from all the studies that we found. And as you can see, the studies are pretty balanced in terms of the effect size. Some of the bigger studies, the one by Cheriton at Harvard, and there was also one by Dr. Bajaj while he was a fellow at Harvard. All of those studies found similar results, and that's pretty much our summative findings. That's it for now. Thank you. Any questions?
Yeah, excellent presentation, great presentation, and short and sweet. Any questions?
Great job, actually. Actually, GFR is a predictor of CFR. I like that observation. Actually, it was expected, but you proved it. Very nice. Nice presentation. Thank you.
Thank you.
Any questions from anybody else? Well, if there are no questions, I think you'll be getting a check in the mail from our president, Dr. Hanumant Reddy, and also from the treasurer, Dr. Rakesh Sharma, for $1,000. Congratulations. And your abstract was selected as the best one in this category. And so we're really happy that you were able to come, and everything has worked out very well. So let's go for the third presentation. And the third presentation is going to be by also from Madhukar Deshmukh Award. And that's going to be on basic science. And the abstract, which was selected as the best one, who's going to present here is Dr. Amit Khera. And it's titled as Machine Learning Enables New Insights into Clinical Significance of and Genetic Contributions to Liver Fat Accumulation. Amit, you're here?
Yes, hello everybody, and good morning, and thank you so much. My name is Amit Khera. I'm a cardiologist in Massachusetts General Hospital in Boston, and started on faculty about a year ago, and have a research group in the Center for Genomic Medicine and Broad Institute, really focused on genetics. So today I'm very excited to focus on how machine learning can help us learn more about liver fat accumulation. So excess liver fat, which is called hepatic steatosis, is a really under-recognized and quite important cardiometabolic risk factor. You can see here that in a normal liver, you can transition to fatty liver disease with important implications for insulin resistance, obesity, and type 2 diabetes. And a subset of these individuals actually go on to develop more advanced liver disease, steatohepatitis, or even end-stage liver disease like cirrhosis. So we wanted to set out for the biggest study to date looking at liver fat in the population. We downloaded abdominal MRI images from the UK Biobank study, a population in the United Kingdom. There were 4,500 actually where a company had previously quantified the liver fat. So we used those 4,500 images to train a machine learning model, and we could near perfectly, correlation over 0.99, estimate the liver fat using just the raw MRI images. So we then downloaded images from 32,000 more people, and in total we had 37,000 people with liver fat quantified, the biggest study to date. And what we found was that the distribution was quite wide, but a significant proportion actually had hepatic steatosis. Now this rate actually varied by race and was highest in South Asians, so 24% of South Asians versus 17, 16, and 14% in other individuals. And this steatosis was linked to higher rates of diabetes, triglycerides, and coronary artery disease as well. So we then said, well, might genetic variants that people have, inborn DNA variation, might that contribute to why some people have more liver fat than others? And so first we did a study where we confirmed that about 33% of the variation is explained by genetics. That's called the heritability. Here I'm showing you on the y-axis is the level of statistical significance, and each dot is a genetic variant. So those above the dotted line are statistically significant. And we first confirmed 3 previously identified variants, but actually newly identified 5 new variants because we had so many people, 37,000. We then said, well, of these 8 variants, some people just by chance, maybe they got unlucky, inherited more of these higher risk variants than others. So we combined these risk variants into a score, these 8 variants, and we said, okay, this is a polygenic score for liver fat. And what I'm showing you here on the x-axis is putting people into deciles of each 10% deciles of the population. And on the y-axis is the percent chance that they went on to develop new liver disease. And what we were able to show is that this score predicts not only liver fat, but also the risk of incident developing very serious liver diseases like steatohepatitis, cirrhosis, and even liver cancer. What about rare variants? So by looking at rare variants in the population, we actually were able to identify a molecular subtype of steatosis. And it turns out that about 0.4%, so 1 in 250 people presenting with steatosis, they inherit a mutation in a gene called ApoB. Now, that gene is actually leads to a more than 10-fold increased higher risk for steatosis, and it's involved in secretion, getting cholesterol and fat out of the liver. And what happens here is that these individuals actually have very different physiology. They're not obese like most people with fatty liver disease. They actually can't get the cholesterol out, so they have low levels of circulating cholesterol in the body. And this actually translates to very low rates of coronary artery disease. So their heart is protected, but their liver has very high rates of steatosis and damage. So this is, again, it's a subtype of regular steatosis. So in conclusion, machine learning, I think, was quite useful for us in leading to a much bigger sample size. We were able to near perfectly estimate the liver fat using this model and based on raw abdominal MRI imaging from 37,000 people. We noted very high rates of undiagnosed steatosis, even when we looked at the medical records. And this rate was especially high in South Asian individuals. And lastly, I think these genetic discoveries may prove useful just in understanding disease biology, risk stratification for future serious liver diseases, and also drug development as well. Thank you.
Thanks a lot. That's a very great presentation, short and sweet. I got a few questions for you. Machine learning, that's a big thing right now. What are the limitations of machine learning?
Yeah, I think it really depends a lot on the project. But what we found is that when we try to apply machine learning to clinical diagnoses, like you have a heart attack or you don't, or even cholesterol levels, you have it or you don't, we have not found it to be that useful. And basic statistical models actually can do basically as well. But where we really see a lot of the benefit is when we have very rich data sources. And by that, I mean raw echocardiogram images, raw MRI images, raw electrocardiograms. So when you have these very rich data sources, that's really where I think you can get a lot of bang for your buck using some of these newer machine learning approaches.
Another question I have got is about the East Asians. Did you mean mainly Chinese and Japanese in the East Asians?
Exactly.
That's what it is? Okay. And another thing, of course, I just saw that you have your own Kera laboratories. Were you able to get that done? In the Massachusetts, within your Harvard University, how were you able to get your lab?
So I'm a cardiologist by training, but I spent actually 3 years in a postdoctoral role, really doing a lot of training in genetics. And then about a year and a half ago, was recruited to stay on as faculty and was able to start my own lab. And we do a lot of computational biology and statistics approach, but we also launched a new preventive genomics clinic. And the idea there is to integrate genomics into clinical care. And so people can come in and right from the start, we can interpret their genome and really help them to overcome any inherited risks that we identify. So anytime you're in Massachusetts, we actually aren't allowed to see out-of-state patients, but anytime you're in Massachusetts, we do virtual patients and e-consults and all those kinds of things.
Well, thank you very much, and congratulations for having your own laboratory. The other thing is, just on a personal note, are you related to Amit Khera, who is quite prominent, has been with us for quite a while in lipidology, so more specialized in hypercholesterolemia?
We're no known relation, but we know each other well.
Oh, I see.
We get confused a lot.
Great. Okay, great. Any other questions from Dr. Hanuman, Jags?
It's a great presentation. Actually, there's a new tool for risk stratification. Actually, I like that. I like the new tool for hepatic steatosis and for not only liver disease but also heart disease.
So, Amit,
Dr. K. Sharma from Clearwater, Florida. Was there any correlation of both this hepatic steatosis with abdominal adiposity? Have you ever?
Yeah, so as of now, we did very crude measures of abdominal adiposity, like waist to hip ratio. And there was a correlation, but it was imperfect. So if you only knew someone's waist hip ratio, you couldn't reliably predict whether or not they had steatosis, even though there was some correlation. But we've now moved on to focusing not just on liver fat, but all the different fat compartments. And one thing I'm excited about is using an MRI, you can actually make a 3D model of the person, like a silhouette of the person. And my goal is to be able to impute, maybe calculate not only their waist hip ratio, which we can do perfectly, but calculate actually the body fat distribution. And in the body fat distribution, we think about subcutaneous fat, that's fat right under the skin, visceral fat, which is actually fat around the organs, which is quite problematic, I think, from cardiometabolic state, and then ectopic fat. Ectopic fat is actually in the organ. So that's like what we were quantifying here with liver fat. So I think there's more work to be done for getting at the abdominal adiposity part, and really just thinking at it, not just very simple measuring with a measuring tape, but actually using gold standard MRI to really quantify it more precisely.
Yeah, it would be fascinating to kind of correlate with the clinical events such as myocardial infarction down the line and so forth. Fascinating. Congratulations.
Okay, any Jags or Vishal, any questions?
Yeah. Hi, Amit. This is Vishal Gupta. I think we met last year at Igor's.
Yeah, definitely.
And you had a really good presentation at that time about polygenic assessment for heart disease. I think since everybody is a cardiologist here and our group is a cardiology group, give us a 1-minute rundown on what you have done in polygenic model for cardiac disease, because I think that'll be something that everybody would like to know.
Yeah, that sounds great. There are very strict rules in that we can't submit anything that's been previously published, so I couldn't submit that here. But we actually included focused polygenic score for Indians specifically for heart attack. But so what is this concept of polygenic scoring? Well, the traditional approach to thinking about genetics for heart attack is looking at rare mutations like familial hypercholesterolemia, about. But turns out those mutations are only present in 1 in 250 people. So the next question is, well, what can we say about the genetic basis for the remaining 99.6% of the world? And that's really what I've been thinking about over the last few years. And what we've been able to do is really integrate information from 6 million sites where my DNA might differ from yours, integrate all of that into a single number. And that number is your polygenic score, which means your inherited risk for heart attack. And it's normally distributed. And what we were able to show is that if you're in the top 5%, so 5% of the population is actually at triple or even quadruple the normal risk. So the risk is actually equivalent to familial hypercholesterolemia, but you get there not by one variant, but the cumulative impact of many variants. And these variants, these individuals are definitely flying under the radar within our clinical practice. And it's really an important opportunity because we know that both with lifestyle or LDL cholesterol lowering, these are the individuals when we go back, they benefit the most from those therapies. So in my clinic, actually, the state of the art for heart attack, someone coming into my clinic, is really to look both for familial hypercholesterolemia mutations and this polygenic score. And so we worked with a genomics company in the Bay Area and are launching the first clinical test just in December in my clinic to look both at the monogenic, will tell you if you have a familial hypercholesterolemia mutation, and the polygenic, tell you what the rest of your genome actually says about your risk into a single model. And so I think we're going to learn a lot just about who wants the test, and we have funding to give the first couple hundred tests for free, but who wants a test and how that ends up impacting their choice of taking a statin, for example, or lifestyle behaviors.
Excellent. You know, we have been looking at, oh, sorry, go ahead. Sorry, Michelle.
For cardiac, especially for coronary artery disease, how many genetic variables are you actually looking at?
Yeah, so what we find, what we find is that looking at all of the variants is the best. And we could do that by comparing just models with only 10 variants, 100 variants, 1,000 variants, and so forth. So we end up looking at about 7 million, actually, different variants. And we show that these models improve performance a little bit over, for example, only 100,000 variants. So the more variants, when you aggregate information, some are, of course, much higher weights than others, but we do get better prediction using all of the variants. And what's nice is that you can assess all those variants very cheaply, and it's cost only about $50 is the technology to get that test. And it's a simple genotyping array or sequencing now has become so cheap. So it's about $50 to get the test, to do the technology. And we launched actually the genetic test we developed for South Asians. We launched in India. A company called MedGenome is based in India. So that's another way to get the test, is go to India. But for now, it's Massachusetts or India. And you can that's a place to get it. But we're hoping to roll out nationwide, of course, soon.
Is that offered by Color? I'm sorry.
So in the U.S., in the U.S. we work with Color, and their test it's currently only available for my clinic, but as a pilot. But again, hoping we can roll it out. But and the test, it costs $250, but that's because they look at the monogenic and the polygenic at the same time. And that includes things like genetic counseling. If you have the variant, they send the kit to your house and isolate the DNA and so forth. So all in, it's $250.
Thank you.
If you were to only do polygenic, it would be under $100.
Okay, well, I just said, we've been looking at also, of course, at the epicardial fat pad and the pericardic fat pad by using both echocardiography and MRI, and the results have been kind of plus minus. But my question is regarding brown fat is supposed to be more protective. You have any comments on that, brown fat versus other fat? And
yeah, I think I think the basic science is pretty compelling, that brown fat, which is just inefficient on purpose and designed to keep you warm, can burn calories. And I think that is likely to be true. The challenge for us is that imaging of brown fat requires very specific protocols. You actually have to basically put the people in the freezer for a while to activate it, so they're very cold, and then use special tracers to actually be able to quantify it. So it has been done, not by my group, but in the New England Journal, there have been a few papers. But there's never been a study like this one where, for example, which is what we would want to do, is be able to do it in 30,000 people and then really look at the genetics of it, the epidemiology of it, and so forth. And because it's so hard to measure and quantify, it just hasn't been done to date.
I see. Okay. Thank you. If there are no other questions, well, congratulations on a great study and great presentation. And you'll be receiving a check for $1,000 from our president, Dr. Hanwant Reddy, and also from Dr. Rakesh Sharma. And of course, Lindy, who is our coordinator, will be sending you an email which will say that you have won this award. And you'll be able to download that on a photographic paper. And if you want, you could put a plaque and hang it up in your office. That'll be great.
Fantastic.
Okay, thank you. Thank you very much. Thank you so much. Hanumant, you want to introduce Dr. Bendito?
Yeah, next speaker is Dr. John Vendito, AstraZeneca company. And thank you very much, Dr. Vendito. We are looking forward to topic, clinical considerations in stroke and also transient ischemic attack. Welcome, Dr. Bendito. Thank you very much for coming and your support. Dr. Bendito, are you here? Dr. Bendito? No, maybe he's not here.
Oh, sorry, I was speaking on mute. Dr. Vendito is in the conference, but I don't think he logged in as the presenter. So if
Sure.
You can make him the host, then he'll be able to present.
Okay. Let's see.
Is there a link? John, yeah, I see him connecting to the audio.
Okay, thank you.
John, you're on mute.
Hi, are you able to hear and see me?
Dr. Bendito, welcome. Thank you very much for coming on aboard. I appreciate your presentation.
Well, thank you for the opportunity. So I understand I may have snuck in backdoor here. So I'm going to share my screen in order to share the slides. So let's hope that this works. Are you able to see my desktop?
We can see it.
Can see your slides, yeah.
All right, good, we're in business. Well, as I was saying, thank you for this opportunity to address your group. And this is a Berlinta talk, a little bit of a promotional talk. So we're going to have some issues and discussions about the prescribing information as we go through the deck. But what I want to talk about today is some exciting new data revolving around our new indication for ischemic stroke and TIA, which is based on the results of the Dallas trial. And in terms of stroke, we understand that atherosclerosis is a major underlying disease burden in the US and around the world. And of course, it manifests as cardiovascular disease, which is the leading cause of death, but not far behind, another manifestation of atherosclerotic disease is stroke. And it's estimated that 7 million Americans over the age of 20 have had a stroke, and that 5 million have had a TIA. And what's troubling, due to the increase in the underlying comorbidities and risk factors that drive risk associated with atherosclerosis, by 2030, an estimated additional 3.4 million individuals over the age of 18 will have had a stroke, equivalent to about a 20.5% increase in stroke prevalence compared with 2012. And approximately 12% of all strokes are preceded by a TIA. So clinically, there's a warning sign of potential stroke in the near future. And what you can see on the right in terms of the breakdown for hemorrhagic stroke versus ischemic stroke. And ischemic stroke is broken down further, it being about 87 to 90% in some studies of all stroke, broken down further into cardioembolic and non-cardioembolic. So the cardioembolic obviously is related to atrial fibrillation, underlying valvular heart disease, or structural heart disease. Non-cardioembolic, more derived from vascular causes, as we'll see. The burden of disease, annual stroke incidence is close to 800,000 patients in the US. And you see this breakdown of first-time stroke, and in gray, about a quarter of strokes are recurrent strokes. So the patient has had at least one prior stroke, 25% of that 800,000. Stroke is the fifth leading cause of death in the United States. Nearly 1 in 4 cases are recurrent strokes, as I said. And 40% of stroke survivors in the US experience moderate to severe disability, resulting in significant limitations to their pre-stroke lifestyles. So there's an enormous burden of illness, which is long-term. Stroke accounted for approximately 1 of every 19 deaths overall in the United States. And again, stroke being associated about 40% of the time with some level of disability. So I mentioned before that we're really now focusing our discussion on non-cardioembolic ischemic strokes. And in terms of their etiologies, the ischemia, as we know, is due to a reduce in blood flow in a specific region of the brain. If it's transient, as a TIA, or if it's permanent, it can result in permanent infarction and damage to the central nervous system. So for non-cardioembolic strokes, they break down into 4 broad categories: atherosclerotic, lacunar, or small vessel, some other etiology other than those 2. So it could be a vasculitis and amyloid vasculitis, for example, and then also an unknown etiology where despite a thorough workup, it isn't clear what the cause of the stroke was, the immediate cause of the stroke was. Again, it's atherosclerosis. So what we know about atherosclerosis in general in other vascular beds, in the periphery, in the cardiovascular system, and in the cerebrovascular system applies. There are general principles. And that atherogenesis, as we know, is a progressive inflammatory process within the wall of the vessel, resulting in increased luminal narrowing over time. And that the platelet plays a crucial role in atherogenesis via secretory function and as modulators of the inflammatory response. And then clearly at the time of plaque disruption, ulceration, or rupture, the platelets become activated and play a role not only in the ongoing inflammation, but also in the thrombosis, which is what triggers the acute clinical event, impeding blood flow and resulting in cerebral ischemia. Now, the majority of recurrent strokes occur within the first 30 days after a TIA or a minor stroke. So it's important that we understand the difference between secondary stroke prevention. For example, you had a stroke in early 2020, and you may have another stroke in mid-2022. We would want to put you on some sort of secondary prevention to reduce the risk of having had that second stroke a year and a half later. What we're talking about today is reducing the risk of recurrent stroke, which is a risk that obtains and is demonstrated really very, very early on because it is related to the underlying culprit lesion, the lesion that first triggered the thrombosis that resulted in either occlusion of the vessel at that site of plaque disruption or triggered the formation of a thrombus at the site of plaque disruption, which then embolized further downstream until it could go no further, resulting in a cerebral infarct. And so you could have extracranial atherosclerotic disease or intracranial atherosclerotic disease. But the common underlying pathophysiology results in recurrent events triggered by that thrombotic substrate at the site of the culprit lesion, which is not yet healed. And it continues, therefore, to trigger a thrombotic response. And so literally, in a matter of days, we can see that the risk of recurrent events shoots up. And therefore, we have a very narrow therapeutic window because the event rates, though they continue to accrue beyond 30 and 60 days in this study, we see really that that curve is pretty steep in its slope in the first several 3 to 4 days, 7 to 10 days, and out to 30 days. Approximately 12% of ischemic strokes, again, are preceded by a TIA, which is a warning. And you can see that even the TIA carries a parallel and increased risk early on for a recurrent stroke, or actually the presentation of the stroke that may have begun with the presentation of the TIA. Now, it's atherosclerosis, it's plaque rupture, and we understand from other vascular beds that the platelets do play a key role in the pathophysiology and the formation of a thrombus. And so what we see here in terms of platelet activation in acute stroke or TIA for the control group on the left in gray versus those patients presenting with stroke or TIA acutely and then 3 months later, we see that there's significant baseline platelet activation. These are circulating platelets that are expressing P-selectin on their surface. So P-selectin is a marker of degranulation or platelet activation. So there's this ongoing process of platelet activity that may be triggered by that substrate, which gradually returns to baseline. And what we see on the right in terms of patients with large vessel acute ischemic stroke compared to control patients without TIA or stroke, or ACS for that matter, that those patients with large artery stroke, carotid plaque that ruptures, for example, are demonstrating a significant rise in the percentage of platelets circulating that are now in a prothrombotic hyperactive state. So it goes without saying that the platelet is playing a key role in the underlying pathophysiology, but we see that there are perhaps different platelet phenotypes, and that those platelets are hyperactive And here's evidence that they're responding in a hyperactive fashion to platelet stimulation, either with ADP on the left or with arachidonic acid on the right. And so in the dark brown, we're seeing the acute situation where there's a marked increase in responsivity compared to controls. And we see that that responsivity, that hyperactivity is remaining in terms of ADP especially. In the post 3-month period, and to some extent as well for the stimulation of arachidonic acid, triggering thromboxane and activation of the platelet via that pathway. So we were saying before that there is an early risk of recurrent stroke, and we see this depicted on the left. We see a KM curve. It's rather jagged. There are few events, right? But nonetheless, early risk in patients with non-cardioembolic stroke, ischemic stroke or TIA, due to a 50% or greater large artery stenosis, are at continued risk of recurrent stroke after that initial event. And then we see that that curve is rising over days. Now, if you look on the right, we see that those patients in the highest tertile of prothrombotic platelets had a marked increase in their risk for recurrent stroke. So what we have is a substrate that triggers thrombosis, platelets playing a key role in that thrombosis being the key underlying etiology for the ischemic stroke. And the more activated your platelets are, the greater your risk for a recurrent stroke in that immediate period following the index event. And so platelet activation, aggregation, and turnover, and we'll get into that, are increased in the setting of following an acute ischemic stroke or TIA. Prothrombotic platelets have high levels of procoagulant proteins on the cell surface and possess high prothrombinase activity, meaning they are the factories generating thrombin that furthers this thrombotic process, the platelets themselves. Prothrombotic coated platelets are elevated following large vessel acute ischemic stroke, intracranial or extracranial, and the presence of prothrombotic platelets in patients with large artery atherosclerotic stenosis, as we saw, is associated with a higher risk of recurrent stroke. So when do we encounter these patients, and when do we start making decisions about how to treat them? And of course, when the patient first presents to the ED with an acute ischemic stroke or TIA, imaging is critical. We want to determine first and foremost if there are any evidence of bleeding, because the stroke may initially be a clinical diagnosis, but bleeding is something associated with that event that would be evident on a CT scan. And then the patients are scored for the TIA in terms of their ABCD squared score, and that's a risk prognosticating score, as well as the NIHSS score. And those scores take into account the acuity that's associated with the stroke at the time of its presentation and the disability associated with that stroke. And the same is true for the TIA. So what evidence do we have now for Brilinta in treating patients presenting with acute ischemic stroke? And so what I want to do is just review quickly all of the indications now for Brilinta, and that the Thales trial has filled in yet another piece of the picture for efficacy with Brilinta in treating patients with the clinical manifestations of their atherosclerotic disease. So it is now indicated in acute ischemic stroke or high-risk TIA to reduce the risk of stroke in patients with acute ischemic stroke, an NIHSS score of 5 or less, or high-risk TIA. And of course, you're familiar with the indications for coronary artery disease without MI or stroke, and that's relatively recent. That's based on the results of the THEMIS trial, and that was a label indication from the FDA that we received this past summer. It is now indicated, Brilinta, to reduce the risk of MI, first MI or stroke in patients with CAD at high risk for such events. And while the use is not limited to this setting, the efficacy of Brilinta was established in a population with type 2 diabetes, again showing the benefit even prior to first MI or stroke for aggressive antiplatelet therapy with ticagrelor and aspirin in the THEMIS trial. I won't go into the other indications, but I think you're familiar with them, the acute coronary syndrome and history of prior MI based on the results of the Plato and Pegasus trials, respectively. As with any antiplatelet, the important safety information for Brilinta is for the 60 and 90 milligram tablets. And so there's bleeding risk. And Brilinta, like other antiplatelet agents, can cause significant, sometimes fatal bleeding. Do not use Brilinta in patients with active pathologic bleeding or a history of intracranial hemorrhage. Do not start Brilinta in patients undergoing urgent coronary artery bypass surgery. And if possible, manage bleeding without discontinuing Brilinta. Stopping Brilinta increases the risk of subsequent cardiovascular events. In a sense, there's a rebound, and that's not unique to Brilinta or unique even to antiplatelet agents for that matter. Aspirin dose and Brilinta effectiveness in patients with ACS, and there's a definite and important relationship. The maintenance dose of aspirin above 100 milligrams reduce the effectiveness of Brilinta and should be avoided. So the maintenance dose for all of the indications would be 81 milligrams daily in combination with Brilinta. The contraindications in dosing, again, as I mentioned, the history of intracranial hemorrhage, active pathological bleeding, or hypersensitivity. And the dosing now for patients with acute ischemic stroke or high-risk TIA is to initiate treatment with 180 milligram loading dose of Brilinta and then continue 90 milligrams twice daily for up to 30 days. The treatment effect accrued early in the course of therapy, as we'll see. Use Brilinta with a loading dose of aspirin, 300 to 325 milligrams, but then after the loading dose, reduce the daily dose to 81 milligrams. And the other posology for the other indications is something that you can find in the prescribing information. So just to level set, remember that ticagrelor is a P2Y12 inhibitor, but it's a CPTP. It is in a different class from the thienopyridines. Ticagrelor and its major metabolite both reversibly interact with the platelet P2Y12 ADP receptor and prevent signal transduction and platelet activation. Ticagrelor and its active metabolite are approximately equipotent. This is a comparison chart comparing ticagrelor to clopidogrel, a thienopyridine, and to aspirin. Now, important characteristics in terms of the pharmacokinetics and pharmacodynamics that might impact the efficacy of ticagrelor versus the thienopyridines. For example, it is a reversible inhibitor, and therefore it can bind to platelets and reestablish an equilibrium with platelets that have now appeared from the bone marrow that have not been exposed to the drug yet. And I'll show you more graphically what that might mean. It is active without metabolism, whereas the thienopyridines bind irreversibly, and clopidogrel particularly is a prodrug. It needs to be activated. And that takes us to the next step, which is the pharmacodynamic effects that are independent of CYP2C19 genotype for ticagrelor, but are very much dependent on CYP2C19 genotype in the case of clopidogrel activation. A good portion of the population, about 30%, are lacking one of the alleles coding for CYP2C19. It is a cytochrome P450 enzyme that is responsible for a second oxidation step in the liver that activates clopidogrel, because the drug you take orally is not active and can't inhibit your platelets until it runs through the cytochrome P450 system. And without cytochrome P2C19, you can't activate clopidogrel and it won't work for you. And that has consequences. In terms of the bioavailability and the further pharmacokinetic properties, which I think are important, we know that ticagrelor is a BID drug, and we know that the metabolite and the parent drug are both active, and the metabolite is active for 9 hours, as is the parent drug. Bioavailability for clopidogrel, on the other hand, is 30 minutes, and bioavailability for aspirin on the other side also is about 20 minutes. Now, aspirin has a different mechanism of action. It inhibits COX-1. It is active without metabolism, and there are no cytochrome P450 issues related to the CYP2C19. This is just depicting what I mentioned, that the ticagrelor goes straight through. It is metabolized in the liver, but does not need to be activated in the liver. It is active when you take the pill, and its metabolite is active. Whereas clopidogrel is dependent on these two oxidation steps, about 85% of that second step going through the CYP2C19. So if your patient is deficient in CYP2C19, they're not going to have a full response to clopidogrel. And for about 5% of Caucasians, 10% of African Americans, and anywhere from 15 to 40% of Asian populations, they're homozygote for the defect. They are lacking both alleles, no CYP2C19 activity, and therefore no ability to activate clopidogrel effectively. Now, I mentioned before that ticagrelor has some pharmacodynamic properties that are unique and different. So what that avails is that ticagrelor is available because of its BID dosing, and we see two peaks here on this chart. And we see that the plasma exposure remains above the IC50 average throughout a 24-hour period in steady state. Because ticagrelor is BID, because its metabolite is active, because both have bioavailability up to 9 hours, and because it's reversible in its binding. While your bone marrow is putting out new platelets all day long, ticagrelor is available to bind to those new platelets. And in the setting of acute stroke, those new platelets or platelet turnover is increased, as we'll see. So I mentioned all of the indications, and they're based on our Parthenon group of studies, which is Plato in ACS, Pegasus in history of prior MI, Themis in high-risk CAD, and now Thales for acute stroke, all showing the benefit of ticagrelor in treating patients with thrombotic complications of atherosclerosis, and now in different vascular beds. So the Thales trial, this is the study design. It was a randomized double-blind placebo-controlled trial, over 11,000 patients from 414 sites across the globe. There were no patients from the US in this study. Patients older than 40 years of age with non-cardioembolic acute ischemic stroke or high-risk TIA presenting within 24 hours of symptom onset, and there were 11,016 patients randomized to receive ticagrelor, 180 milligram loading dose, followed by 90 BID and aspirin, versus aspirin, a 300 to 325 loading dose, followed by 75 to 100 milligrams daily plus placebo. The primary efficacy endpoint was stroke, and that encompassed both ischemic or hemorrhagic stroke or all-cause death. The pre-specified secondary efficacy endpoint was ischemic stroke alone, and then the primary safety outcome was Gusto-defined severe bleeding. The key inclusion criteria, again, was an acute stroke, ischemic stroke with an NIH-SS score of less than or equal to 5, and persistent signs or symptoms at the time of randomization, or an acute ischemic brain lesion demonstrated by CT or MRI. And for patients with TIA, the ABCD squared score was greater than or equal to 6, or these were patients with symptomatic intra or extracranial arterial stenosis greater than or equal to 50% narrowing of the lumen of an artery that could be clinically related to the presentation index event. Randomization was within 24 hours of symptom onset. Strokes evident upon awaking from sleep within 24 hours from last reported normal were also included. Again, age, and then the patients had to undergo a CT or MRI scan after symptom onset to rule out intracranial bleeding or other conditions that could account for the neurologic symptoms or contraindicate the study treatment. I'll go quickly through the exclusion criteria. They're pretty standard with regards to antiplatelet agents, but particularly in the stroke population, intravenous or intraarterial thrombolysis or mechanical thrombectomy within 24 hours of randomization was an exclusion criteria. Any patient with a history of any atrial fibrillation, flutter, ventricular aneurysm, or suspicion of cardioembolic cause for TIA or stroke was excluded. Any patient with a planned carotid endarterectomy that would require halting the study treatment within 3 days of randomization or require unblinding was excluded. Any planned use of dual antiplatelet therapy or any other antiplatelet or anticoagulant for that matter was an exclusion criteria. Patients with a history of prior intracranial hemorrhage were also excluded, as well as GI bleeding within the past 6 months or any major surgery within 30 days. This was the flow diagram. So 11,073 patients were enrolled, 11,016 were randomized, and coming down, including the primary efficacy and safety analysis, 5,523 for ticagrelor and 4,993 for placebo. These are the baseline characteristics, and they're fairly standard for a population presenting with stroke. We can see again that there was very little North America involvement because this was not a US study. There was some enrollment in Canada, predominantly Asia and European enrollment, and predominantly white and Asian race enrollment in the study. Medical history, this is again a fairly representative stroke population, hypertension and smoking being particularly prevalent, hypertension especially 77 and 76%, diabetes and just under 30%, previous ischemic stroke 15 to 20%, previous TIA about 5%, aspirin prior to the index event, these were patients about 13.7 and 12.4, and then any clopidogrel prior to the index event, and that was low, 1.4 and 1.4 in both groups. In terms of the baseline characteristics for the qualifying event, the index stroke or TIA, most of the index events were ischemic strokes, 91.1 versus 8.9 in TICA group, and 90.2 and 9.8. So about 10% or just under were TIAs, and 90% in both groups were ischemic strokes. The time from symptom onset, less than 12 hours in about a third of the patients. In terms of the ABCD squared score qualifying the severity and risk of the TIA, this study went out to 6 and under, and you can see less than 5 was about 1.1%, and 6 to 7 of the 10% was in the 7 to 8% or 8.5% in the placebo group. Now for NIHSS score, this is a study where compared to previous ischemic stroke studies, we've gone a little further in terms of the risk based on the NIHSS score. So less than or equal to 3 was 60.8 and 60.3%, but in this study in Thales, NIHSS score greater than 3 was present in 30% of the TICA patients and 29% of the placebo patients. So this is the primary efficacy outpoint, the composite of stroke or death at 30 days. For the placebo, it was 6.5, and for ticagrelor, it was 5.4 for the composite of stroke or death at 30 days. The point estimate was 0.83, so there's a 17% relative risk reduction, an absolute risk reduction of 1.1, and a number to treat of 92. So the treatment effect on stroke and death does accrue early over the first 10 days, but was sustained at 30 days. And although not studied, it suggests that perhaps a shorter treatment result might result in similar benefit with reduced bleeding. But this is something that's true for the overall cohort. And I want you to hold judgment on that until we see all of the data. In terms of the composite of the primary outcome, it was driven primarily by a reduction in stroke. So stroke or death, 5.5, as I mentioned, 6.6 for the placebo. In terms of ischemic stroke, it was 5.1% versus 6.3. That's the combination of ischemic stroke and hemorrhagic stroke. And for death, it was 0.7 and 0.5. So the overall composite, in essence, is a net benefit because it includes ischemic stroke and hemorrhagic stroke and death. Events that might be increased or decreased depending on as a function of ticagrelor versus placebo. And we can see that the overall primary outcome was positive. The secondary efficacy endpoint of ischemic stroke is more specific to our concerns in reducing the risk of stroke in these patients. And you can see that in terms of the efficacy, the KM in the ticagrelor group was 5%, versus 6.2% for placebo and aspirin. The point estimate is 0.79, and the p-value is significant at 0.004. I'll go quickly to show here that there's consistency across all of the pre-specified subgroups, that ticagrelor and aspirin is superior to placebo and aspirin. This was true for time from index event to loading dose to randomization. This was true for diabetes, hypertension, and prior ischemic stroke or TIA at baseline. And we can see this was also true for aspirin, prior ischemic heart disease. The number of events and patients at risk was low, and the confidence intervals are quite wide as we go further down the pre-specified subgroups. And now, importantly, this is the primary safety endpoint, the primary safety endpoint being gusto severe bleeding at 30 days. The point estimate is 3.99. The confidence intervals are wide at 1.74 to 9.14, and the number needed to harm was 263. So ticagrelor and aspirin, 0.5%, placebo and aspirin, 0.1%. So while the point estimate is 3.99, bear in mind that the absolute relative increase, the number of bleeding events, was low in the study. Looking at the KM curves, we can also see that the bleeding tended to accrue early in the ticagrelor arm and was uniform over the course of 30 days. And probably by chance, we don't see any bleeding events in the aspirin group until after 10 days. And then the bleeding events started to accrue. Nonetheless, the point estimate reflects the difference over the course of 30 days in the two arms, and it was 3.99 for the overall cohort. And we'll take a look at some more important subgroups for safety and efficacy in a bit. This is the breakdown in terms of gustosevere bleeding. As I said, 0.5 and 0.1. Intracranial hemorrhage or fatal bleeding for ticagrelor 0.4 and for placebo 0.1. Intracranial hemorrhage was 0.4 and 0.1. There was a numerical increase in fatal bleeding, 11 and 2, but the percentages were too low really to calculate a KM at all. And in terms of hemorrhagic stroke, again, event rates were low, 0.2 and less than 0.1% for placebo, but it was 10 versus 2. So gusto moderate or severe bleeding, widening the spectrum of bleeding events, there were 36 or 0.7% in the ticagrelor group versus 11 or 0.2% in the placebo group. This is an on-treatment analysis, and really there are no surprises here. So for the patients who were on treatment in the analysis, we see that the point estimates are in the same range, and we see that the safety, which is probably more impacted by on-treatment versus the ITT, shows us that gustosevere bleeding, the point estimate bumping from 3.99 to 4.35, but the percentages and the KM percentages really not changing between the on-treatment and ITT safety analysis. So in summary, for the overall cohort, we see that ticagrelor plus aspirin significantly reduced the composite risk of stroke or death by 17%, which was primarily driven by a reduction in stroke at 30 days in patients presenting with acute ischemic stroke or TIA compared to placebo plus aspirin. Ischemic stroke, the secondary outcome, was reduced by 21% with ticagrelor plus aspirin compared to placebo. In terms of safety, gustosevere bleeding occurred in 0.5% of patients who received ticagrelor plus aspirin versus 0.1% of patients who received the placebo. Now, let's look at some of the pre-specified subgroup analyses, and I will bring your attention back to this efficacy slide for a moment and show you that one of the pre-specified secondary outcomes was total disability at 30 days. And we did a pre-specified exploratory analysis of disability greater than MRS score 2, the MRS score being the way we score the patient's disability. And we looked at only the patients who had a recurrent stroke. And so these are the baseline characteristics, therefore, of the patients in the disabling stroke analysis. So these are patients' baseline characteristics at 30 days, MRS score 0 to 1, which is essentially no disability, and an MRS score of greater than 1. So it is a great concern in terms of the overall burden of illness to society, and particularly to a patient who's having a stroke. I mean, the dreaded fear of having a stroke is that you're going to be left with permanent disability. So the ability to lower disability associated with a stroke is a very important feature in the overall efficacy of a treatment for ischemic stroke. So we see really that there's no significant differences equally distributed in terms of the baseline characteristics for these patients. In terms of hypertension, again, dyslipidemia, and diabetes, all of these baseline characteristics are equally distributed and not all that far off from those patients in the main cohort. What we see here in terms of the index event is that perhaps there is a relationship now between the NIHSS score and the percentage of patients who are having a disability associated with their stroke. And we will do the specific analysis and really drill down into the baseline factors, the clinical factors that drive both risk for recurrent stroke and the risk for that recurrent stroke having disability associated with it. But for all of these baseline characteristics, we see that they were equally distributed between the placebo and ticagrelor arms. So in this analysis of only the patients who had an index event and a recurrent stroke, we see that the disability at 30 days was impacted favorably by ticagrelor and aspirin versus placebo and aspirin. So if your MRS score is greater than 1, you have some disability and dependency. There was a significant improvement with ticagrelor. If your MRS score was greater than 2, a moderate disability with some dependency, The point estimate was 0.78, and the confidence interval is 0.63 to 0.97. It suggests, too, that ticagrelor reduced the disability with an MRS score greater than 2. The benefit was lost at an MRS score greater than 3 for the disability that that patient had after their index and a subsequent stroke, assessing both at 30 days. But clearly there is a reduction in the disability in those patients having an index and recurrent event. And we see this as well in terms of an ordinal shift in the number of patients having a stroke associated with disability, and the burden of that disability, such that the ordinal analysis of recurrent ischemic stroke resulted in a 23% reduction in overall disability with the use of ticagrelor plus aspirin compared to placebo and aspirin. So that's a very important finding and a unique finding for dual antiplatelet therapy in the treatment of acute ischemic stroke and TIA. In terms of the primary efficacy endpoint in patients as a function of their MRS greater than 1 or MRS 0 to 1. So comparing patients who had a disabling event versus those with no disabling event, you can see that there's a marked difference in the event rate and a difference in the efficacy as well of ticagrelor and aspirin versus placebo and aspirin. So ticagrelor is the maroon curve versus the gray curve, and there's a much higher event rate for recurrent events in those patients with disability. And the benefit seems to be greater in those patients having a disabling stroke. But there are other variables, and there's a more complex interaction than disability in the overall cohort alone. And we'll see that in a moment. So what we're looking at here is safety outcomes in those patients, and the safety outcomes in patients with and without disabling stroke subsequently are consistent with the overall cohort. If you look at premature patient discontinuation or due to study drug or bleeding, we can see that that was, as you might expect, given that there was more bleeding, that there was going to be a significant increase in study drug discontinuation due to bleeding. But there was no other significant difference other than the fact that there is slightly more bleeding in those patients who had disability, but again, the numbers are small, and it's difficult with wide confidence intervals to say confidently that this was a trend. However, again, as we'll see in a moment, disability is tied to another factor. This is the predictors of disabling stroke. So if you had ipsilateral stenosis, the second one down, we see that that had a odds ratio of 2, of doubling your risk for a disabling stroke. So too did an NIHSS score of greater than 3. And that was about 30% or more of our study population. There, the odds ratio was nearly 4, a 4-fold increased risk of having a recurrent stroke with disability. Race played a part in this, as did age and systolic blood pressure, and so did diabetes with an odds ratio of 1.43. Remember, diabetic patients also have their own unique hyperthrombotic platelet phenotype. Diabetic platelets are hyperactive and demonstrate a lot of the same properties I showed you earlier in the presentation. Again, the safety outcomes for disabling stroke, as I showed you, are consistent with the overall cohort. So another pre-specified analysis was ipsilateral atherosclerotic stenosis. So remember what we were saying before about 4 causes of ischemic stroke, and atherothrombotic disease is an important underlying etiology. About 40% of ischemic strokes present with ipsilateral atherosclerotic stenosis. So the idea is that there's plaque in the large artery, extracranial, intracranial, that plaque becomes disrupted, thrombus forms, either occluding at the site of disruption or embolizing distally and causing a stroke further downstream in the brain. So rupture of atherosclerotic plaque in an intracranial or extracranial artery is the main cause of ischemic stroke. Platelet aggregation induced by an unstable carotid plaque contributes to thrombus formation in a significant way. And the presence of a thrombotically active carotid plaque or extracranial plaque in a vessel triggers the activation of platelets, fibrin generation, and elevates the risk for recurrent stroke. Now, we did a pre-specified subgroup analysis in thallus, and this was the breakdown. So all patients, as I mentioned, had some imaging, and the critical component there was to rule out any evidence of intracerebral hemorrhage or bleeding associated with the stroke. about 80% of the patients had imaging that revealed whether or not they had atherosclerotic disease. And the pre-specified ipsilateral atherosclerotic subgroup criteria were met in 21.1% of the patients. And so for the patients with ipsilateral stenosis or plus IS, 1,136 patients, and no ipsilateral stenosis, 4,387 patients. In the ticagrelor group, and with was 1,215, and without was 4,278 in the placebo arm. So we had good numbers and good power. So this was a very unique and very important analysis in Thales. Again, because Thales was such a large study overall. So ipsilateral atherosclerotic stenosis was established, as I said, in 21.3% of the overall Thales population. It was distributed equally in the two arms, ticagrelor and placebo, and about 79.9% of patients enrolled in Thales underwent imaging of the intracranial and extracranial arteries to make the determination. The qualifier for this subgroup analysis was intra-extracranial artery narrowing by 30% or more. That could account for the clinical presentation. Artery stenosis diagnosed using vascular imaging data, CT, MRI, CTA, ultrasound, any way of establishing the diagnosis was acceptable. Evidence of narrowing categorized to 70 to 90, 50 to 69, 30 to 49, or less than 30, or simply the presence of atherosclerotic plaque or no atherosclerosis was the scoring. So you see the distribution of ipsilateral atherosclerosis by region, and there's an interesting breakdown. There seems to be a differential, Europe versus Asia, Australia, in terms of the prevalence of intra versus extracranial. Far more prevalent extracranial in the European population at 30% and at greater than 50% versus intracranial disease for the Asian, Australian patients entered into the trial. These are the baseline characteristics, and again, are consistent with the overall baseline characteristics of the study. And you will see that there is a slight increase in comorbidities and baseline characteristics consistent with the presence of atherosclerosis. Although remember, hypertension and diabetes, hyperlipidemia raise the risk of stroke regardless of whether it's atherosclerotic or non-atherosclerotic small vessel disease. These are the baseline characteristics, again, equally distributed across the two groups and consistent with what we saw in the overall cohort for those patients with and without ipsilateral stenosis greater than 30%. In terms of the qualifying events and the time from randomization, again, roughly a third of the patients had NIHSS score greater than 3, as we see here. And ABCD score distribution was also the same, as was the time and the type of presentation, ischemic stroke, again, being the vast majority in both ticagrelor and placebo groups. Now, remember what we saw in terms of the KM curve for the primary efficacy endpoint of stroke or death in patients with or without ipsilateral, the overall cohort. We had a number needed to treat of 92, an absolute risk reduction of 1.1. Now we see that there's a big difference in these two groups. So placebo versus ticagrelor, ipsilateral stenosis in both arms of in that arm of the study, there's a big difference. One, in terms of the absolute risk, you can see that there's a much higher rate of recurrent stroke in this population. The curve is steep early on and then tends to level off, but they're continuing to accrue events out to 30 days. But the absolute risk reduction is now 3% in patients with ipsilateral stenosis, and the number needed to treat drops from 92 to 34. Now, there is still efficacy in those patients with without ipsilateral stenosis, and the p-value for interaction overall is negative. So even in those patients without ipsilateral stenosis, those results are consistent with the overall outcome of the study, but we see clearly that there's greater efficacy demonstrated for the primary outcome in these patients with ipsilateral stenosis. And this was also the case for the patients with ipsilateral stenosis with respect to the secondary endpoint of ischemic stroke alone. So with ipsilateral stenosis, the KM in the ticagrelor group was 7.6, and with ipsilateral stenosis in the placebo, it was 10.5. The point estimate drops down to 0.72, and the upper limit of the confidence interval is 0.95. In patients with ischemic stroke without ipsilateral disease, the KMs are 4.3 and 5.0 for ticagrelor and placebo, respectively. The point estimate, though, reflects a 16% relative risk reduction, but the upper limit of the 95% confidence interval crosses the line of unity. In terms of the exploratory endpoint, again, for disabling stroke or death greater than MRS1, it wasn't significantly different in the overall cohort. But if we start to look at the patients with ipsilateral disease, we see a trend that's growing in that subgroup of a subgroup, granted, but we see a trend that's starting to develop in that there was a difference in terms of disability. And remember, I said earlier that there's this interaction between disabling stroke and the presence of ipsilateral atherosclerosis. The odds ratio was greater in that subgroup. In terms of safety, there's another very interesting breakdown here. So we see far greater efficacy in the patients with ipsilateral stenosis greater than 30%. And we see, too, a dichotomy that is starting to develop in terms of safety. In terms of gustosevere bleeding, yes versus no, ipsilateral disease, yes or no. For gustosevere bleeding in the ipsilateral atherosclerotic group, 4 gustosevere bleeding events in the ticagrelor group, 3 in the placebo group. For those without ipsilateral atherosclerosis, gustosevere bleeding, ticagrelor 24 events, placebo 4 events. For intracranial hemorrhage or fatal bleeding, yes versus no, 4 versus 18, 3 versus 3 for ticagrelor and placebo, respectively. In terms of fatal bleeding, 1 versus 1 for the ipsilateral atherosclerosis. Without ipsilateral atherosclerosis, it's 10 versus 1. The same trend maintains for intracranial hemorrhage, for hemorrhagic stroke, for gusto moderate or severe bleeding. So all of these results are exploratory. Any p-values that you see are totally nominal. So we can't make any firm conclusions here, but we definitely know that there seems to be a trend. And that trend being that patients with atherosclerotic disease have greater efficacy than those without and appear to have better safety than those without. Well, what would be the possible explanation? We know from other studies in our study of small vessel, non-large vessel strokes, that they do not benefit as much from antiplatelet therapy, and there may be more bleeding associated with antiplatelet, antithrombotic therapy as well. So it is consistent with a previous body of evidence and a very interesting and potentially one of the largest analyses that we've seen in a population like this. So in summary, again, I need to just go over safety and warning and precautions. This is all information that you can get from the prescribing information. And anytime, if you're not familiar entirely, I recommend that you do read the prescribing information from time to time. There's a lot of good information in there. And I'll go through all of these just quickly in terms of the warning and precautions. In terms of dyspnea, I think you're familiar with that. Ventricular pauses, bradyarrhythmia, because of the impact on the metabolism and uptake of adenosine. It can cause ventricular pauses. This was due to evidence we saw post-marketing and not anything that we saw in a pre-specified Holter analysis in the Plato trial way back in the almost 12, 13 years ago. In terms of avoiding Brilinta in use with patients with severe hepatic impairment, it wasn't studied. Patients on dialysis, not studied. And in patients with heparin-induced thrombocytopenia, this is new. And I just want to bring this to your attention. You can get false negative results for HIT-related platelet function tests, including the heparin-induced platelet aggregation or HIPAA assay with Brilinta. And so Brilinta is not expected to impact the PF4 antibody testing. So you must be careful if you're trying to rule out heparin-induced thrombocytopenia in a patient who's had Brilinta, that there could be an issue because the Brilinta remains in the plasma and can inhibit the normal platelets that are introduced into the assay, again, because of its reversible binding. But nonetheless, I just want to point that out because that's a new addition. All of this other information is pretty standard and in the PI, and I recommend you see that. So in summary, ticagrelor plus aspirin reduced the risk of stroke or death by 17% at 30 days in patients with acute ischemic stroke or TIA compared to placebo. Ischemic stroke was reduced by 21% with ticagrelor plus aspirin compared to aspirin alone, the point estimate being 0.79, and a significant benefit with a p-value of 0.004. Gusto-severe bleeding was elevated in the overall cohort, the point estimate being 3.99, and disabling stroke or death was reduced by 15% with ticagrelor plus aspirin compared to placebo plus aspirin, with a reduction in overall handicap burden by 23% in those patients with recurrent stroke. In patients enrolled in Ballas trial who had ipsilateral stenosis greater than 30%, ticagrelor plus aspirin significantly reduced the risk of stroke or death by 27% compared to placebo plus aspirin. The exploratory endpoint had a point estimate of 0.78 and a number needed to treat of 34, and showed no significant increase in gusto-severe bleeding, 0.4 versus 0.2%. The number needed to harm is 951. Now, granted, this is a subgroup of a subgroup, and these p-values are exploratory, but I think it shows an exciting and interesting trend in treating these patients with ipsilateral atherosclerotic disease who are presenting with acute ischemic stroke and TIA. By treating them with ticagrelor and aspirin versus aspirin alone, knowing that the platelet is playing such a crucial role in the underlying etiology and pathophysiology, we are in essence hitting that proverbial nail on the head with this treatment. I'm going to stop here, and I believe that we'll have some time, I hope, for questions and answers.
Yeah, well, sure. Thank you very much. I appreciate it. So, do you have any questions? Great presentation.
Sure.
Dr. Nanda?
Yeah, no, I thought somewhere you mentioned that the odds ratio for stroke actually was, in Asians, was 1.93. Was that diabetes a factor in that, or that was just a multivariate analysis?
So that was in the Cox regression and then in a multivariate analysis. So in the Cox regression model, we saw that the NIH score greater than 4 to 5 in this study, age, diabetes, presence of ipsilateral disease was a predictor of recurrent events. We saw that those patients with ipsilateral atherosclerosis had a twofold increased risk in this study for recurrent stroke. And we saw in terms of disability that in the multivariate analysis, the odds ratios were elevated for patients who had ipsilateral disease, who had an NIH score of 4 to 5, basically greater than 3. Diabetes also being an increased risk factor. And we know that diabetic platelets pose a problem, both for aspirin and for clopidogrel. Diabetic platelets tend to switch more to COX-2 dependency and may not be as sensitive to aspirin. And we know from all the changes related to hyperglycemia that there's upregulation in diabetic platelets of their P2Y12 receptors. There's altered responsivity to thrombin, and it's enhanced, and there's altered and increased prothrombinase activity. So not only does diabetes change the platelet, but it also changes the endothelium and creates a more prothrombotic milieu. So that's something that goes against diabetic patients, unfortunately, wherever atherosclerosis is present.
Were there enough Asians in your study that you could differentiate the Southeast Asians versus the East Asians? Because, as you know, the risks are different.
No, right. And so when we looked at those populations, grossly in the overall cohort and even in the subgroups, they were grouped as either being from Europe, North America, or Asia/Australia. And so, yeah, there's a tremendous amount of heterogeneity.
Right.
The majority of the Asian populations were from China. But still, there were patients enrolled across. And in terms of, for example, CYP2C19 activity, we know in general that Asian populations have a higher prevalence of being homozygote for the defect and not being able to activate clopidogrel. But that varies from anywhere from 15 to 40% of Asian populations having that prevalence. But there's a higher prevalence overall for heterogeneity, for being maybe intermediate responders. And that was something that was brought out in the CHANCE trial. So there's a trial looking at clopidogrel and aspirin versus aspirin alone in an NIH score population of 3 or less, but presenting with acute ischemic stroke or TIA. And in those patients, if you were a carrier of the loss of function allele, you didn't do any better than aspirin. If you were a non-carrier and could activate clopidogrel, you did much better than aspirin. So there's a real problem there with CYP2C19 status. And you've got a very narrow therapeutic window when you're treating a patient presenting with acute stroke. It isn't that they may have an event 3 months from now. They're going to have an event potentially in the next 48 hours or out to 10 days or 30 days because it's related to that culprit lesion. And until that culprit vessel heals, there's this thrombotic substrate that could precipitate events. And so you want something that's going to work reliably, work in everyone, and not have to worry about CYP2C19 status. And that's not an issue with ticagrelor because it's metabolized through the CYP3A4 pathway and not through CYP2C19 at all. And of course, its onset is more rapid, and its platelet inhibition is greater, and it is more reliable in terms of steady state because of its BBB dosing and reversible binding. So when you've only got this amount of time to make a difference, I guess you want to get in there and make a difference quickly.
So the reason I was asking this question was because we had done a survey of around 1,000 Asians in Atlanta area some years ago, and found that the prevalence of stroke was actually 2 times higher than it was in India, and that was in other ethnic groups in the United States. That's the reason I was asking the question. Any other questions?
A lot of Asian groups will come to the United States and change their lifestyle and manifest the complications of atherosclerosis and even premature, for example, coronary artery disease. Because they've changed their lifestyle, their diet and lifestyle, and they'll manifest some predisposition that wasn't really showing up as a phenotype when they were living in a different environment with different lifestyle and diet.
Thank you very much, Dr. Vandita. So we appreciate you and appreciate Dr. Chowdhury for great presentations. We have learned a lot. Very enlightening, very thorough. I appreciate it very much, and we appreciate your support from AstraZeneca for the ASCIO. Great relationship. I appreciate it very much. Naveen.
Thank you, Dr. Reddy. Thank you all.
Thank you. Thanks a lot.
Good afternoon.
So what I'll also thank not only Dr. Chowdhury and Dr. Vandita, also the IPCA laboratories for hosting this conference, and all these nice people, Chanchal, Aditya, Poonam, Johnny, Edwin. We appreciate them very much. Dr. Naveen?
Yeah, I think we would be asking some of you for your biodata so that we could put that in our AACI newsletter, and also we'll be sending you by email appreciation for what you have done on behalf of our association, and then I think you can download those, and some of you may want to even frame that. So we'll take care of that because Lindy is not here for this couple of days. She's busy with some family matters, so she'll be back next week, and we'll be writing to all of you. So really want to, just as Dr. Hanumanth Reddy mentioned, we really appreciate everyone's help very much for this very successful symposium. And many have told me that they will be looking at this later on. So we'll make sure that this will be available for at least 30 days. So many more can actually learn from the 2 talks that both Ravish and John have given. Thank you very much. Thank you.
We appreciate the audience too. Appreciate everybody who participated and spent their valuable time. Thank you very much. And next, stick around for the next segment, which is going to be very exciting from Bollywood. The Saregama prize winners, award winners, Dr. Chakrabarti is going to be on board very soon. I have to take a little break. And actually, Naveen, we are going to stick around a little bit because I have to take a break.
Yeah,
Dr.
sure.
Gupta and everybody, Jax, thank you. And Rakesh.
So this will be the last bit. This is the last portion of our presentation, and then we'll be we'll be adjourning exactly at 12. So we have got another good half an hour or so, a little bit more than half an hour. So that'll be great. So hope all of you would stay and enjoy the.
Amit is there. Sorry to interrupt. Dr. Amit is there. Thank you very much. Welcome, Amit. Thank you very much indeed. I'll take a little break. I'll come back. Thank you.
Sure. And Amit, thank you very much for this. This is very much appreciated. What you are doing is greatly appreciated. So please go and take over from now. Thank you.
So are we ready for the music session now?
Yeah, sure.
Good. Perfect. Okay. We were a little early, but I think I can get started, and I'll just let the other people know because we were supposed to start at 11:30. But I'll let them know they're all ready anyway. So so I'll just let them know that that we are ready. Just give me 1 second. Okay, we are going live now. Aditya, if you can hear me, we will go live right now with me while they come in, okay? Aditya? Okay, let me see. Just give me 1 second and we'll get started. I'm looking for the guys here, so I'm going to actually join. I'm going to log off from here. I'm going to join on my cell phone. Okay?
Yeah, sure. We're about 6-7 minutes early.
Yeah, that's fine. They're all ready. We're all
okay.
Just 1 second. The main show. Okay, good. Aditya, please let me in. I don't know who is handling the main session. Please let me in. There you go. Perfect. There are two places where I am on. Do you want me to put it sideways or longitudinally? Aditya?
Also sideways.
Sideways? I'm putting it good deal. Perfect. And actually, I have it on both places. So let's try this and see if this works. We're going to get started before they join in. They need to come in as soon as possible. I'm going to let them know that that we're going to we've got about 2-3 minutes. I'm going to start in 2-3 minutes, and and I'm going to just text them, telling them that we're going to get started. I will tell them that I'm going to start it. I'm starting it.
Sir, you can close the video from your alternative mobile, sir. So from the device which you are operating, so you are clearly visible.
Okay. No, I'm just going to go do a text. I'm starting the show. You guys join with the actual link. Okay, so send them the actual link again so that they have the actual link. I'm logging out from there. Okay. I'm leaving from this side. All right.
So you need to unmute, sir. You are muted.
Okay, guys. While the professionals are coming, I'm kind of one of those people who'll open for them. So these guys are awesome, and they are in Kolkata. We had a little trouble getting the dry run done, and so that's why they are going to be joining in very soon. But meanwhile, as I've done for years and years and years, I will get started with the ASIA program, and as I've done also for years, and as Dr. Nanda and Dr.
Ready.
As Dr. Nanda and Dr. Reddy have liked this song, I always do this one. Let me just start with that intro medley, Pukarta Chala Hu Main. Your favorite, Dr. Nanda.
Okay, thank you.
Ready, guys? Aditya, please let me know if everything is okay. You can text me and let me know if there's anything wrong.
पुकारता चला हूँ मैं गली गली बाहर की, बस एक जुल्फ की, बस एक निगाह प्यार की। पुकारता चला हूँ मैं गली गली बाहर की, बस एक जुल्फ की, बस एक निगाह प्यार की। पुकारता चला हूँ मैं। सुनी मेरी सदा तो किसी जमीन पे रही यही लगन तो दिल जवान, असर भी हो रहेगा हसीन पे। घटा उतर के आ गई जमीन पे, रही यही लगन तो दिल जवान, असर भी हो रहेगा हसीन पे। पुकारता चला हूँ मैं गली गली बाहर की, बस एक जुल्फ की, बस एक निगाह प्यार की। पुकारता चला हूँ मैं। This was Mohammad Rafi. Next is Mukesh. किसी के मुस्कुराहटों पे हो निखार, किसी के दर्द मिल सके तुम्हें उधार, किसी के वास्ते हो तेरे दिल में प्यार, जीना इसी का नाम है। किसी के मुस्कुराहटों पे हो निखार, किसी के दर्द मिल सके तो ले उधार, किसी के वास्ते हो तेरे दिल में प्यार, जीना इसी का नाम है। माना अपनी जेब से फकीर है, फिर भी यार दिल के हम अमीर हैं। माना अपनी जेब से फकीर है, फिर भी यार दिल के हम अमीर हैं। मिटे जो प्यार के लिए वो जिंदगी, चले बाहर के लिए वो जिंदगी, किसी को हो न हो हमें तो एतबार, जीना इसी का नाम है। नेक्स्ट इज हेमंत कुमार। याद करके हमें यूं न जाइए, आपको हमारी कसम लग आए। याद करके हमें यूं न जाइए, आपको हमारी कसम लग आए। Aditya, make speaker view, please. Make speaker view. देखिए वो खाली खाली बदलियां, जुल्फ की घटा चुरा न ले कहीं, चोरी चोरी आंखें शौक बिजलियां, आपकी अदा चुरा न ले कहीं। दो कदम अकेले न आगे बढ़ाइए, आपको हमारी कसम लग आए। बेकरार करके हमें यूं न जाइए, आपको हमारी कसम लग आए। लास्ट but not the least, किशोर कुमार। नखरे वाली नखरे वाली नखरे वाली देखने में देख तो है कैसी भोली भाली अजनबी ये छुरिया दिल पे डाले डोरिया अजनबी ये छुरिया दिल पे डाले डोरिया मन की काली वो तो कोई और थी जो आंखों से समा गई दिल में बिजलिए डुडलू बिजलिए बिजलिए डुडलू बेरहम बेवफा अपना कुछ अता पता बता तो दे ओ बेरहम बेगली बेकशी कुछ तो कम हो फिर से मुस्कुरा तो दे ओ बेरहम कोई और थी जो आंखों से समा गई दिल में वो तो कोई और थी जो आंखों से समा गई दिल में डिडलिए डुडलू डिडलिए डिडलिए डुडलू डिडलिए Thank you, thank you, thank you, thank you. Are other musicians ready?
That's a great song. You could hear it very well.
Okay,
Yeah.
I'm going to sing one more song and give it to them. Okay, just last thing. Sorry. So basically, what I'm going to do is introduce them. You are right on the time, and we're going to. कहना है आज तुमसे ये पहली बार हो तुम ही बुलाई जीवन में मेरे प्यार 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 कहना है आज तुमसे ये पहली बार हो तुम ही बुलाई जीवन में मेरे प्यार 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 तुमसे कहने वाली और भी है प्यारी बातें तुमसे कहने वाली और भी है प्यारी बातें सामने सबके बोलो कैसे कह दूं सारी बातें आज मगर बस इतना ही करना है इकरार तुझी बुलाई जीवन में मेरे प्यार प्यार कब से दिल ने मेरे मान लिया है तुमको अपना कब से दिल ने मेरे मान लिया है तुमको अपना मेरी देख रही है चार सोचे ये सपना तेरे गले में डाल रही हो तुम बाहों का हार तुमकी तो लाज बची मेरे प्यार प्यार कहना है आज तुमसे ये पहली बार हो तुमकी तो लाई बची मेरे प्यार प्यार हो तुमकी तो लाई बची मेरे प्यार प्यार Thank you. Virtual audience, I don't get any claps, but I think you may have enjoyed it. This is, thank you, Dr. Nanda. Thank you, Ji. So I can see everybody, and I want to now hand it over to our professionals. Like I said, I was warming the stage for Nanda. How are you, Auntie?
Thank you. Very good. Yes, she said hello to you also.
I was warming the stage for the real artists to come in. My friend, dear friend, and he's my younger brother. He, spent some time with me, and I spent some time with him in Kolkata. Amazing individual, great music director, Bollywood playback singer, and hang on one second. Okay, now it's better. So I want to introduce none other than my friend who is a Bollywood playback singer and music director. He was the winner or runners-up of Saregama 2010. His name is Bishak Jyoti. Please give him a big hand. And along with him is none other than the sensational Sanchita. That name is very dear to me. You guys might know why. But Sanchita is an amazing upcoming singer. She was Saregama Junior Champion and is as a playback singer. Amazing singer. And I heard her last week also in a show which I conducted here. You are in for a treat. So please give it up for Sanchita and Bishak. Over to you.
Your internet connection is stable.
Aditya, what happened? Can you just put them on?
Sir, they are muted, sir. They have to unmute themselves, sir.
I'm sorry, I couldn't hear. Once again, Aditya.
Sir,
What happened?
They have to unmute, sir. They are muted.
Okay. Yes, guys, unmute. Can you hear me? Vishak, unmute. You got it? Bishak, say hello. Vishak?
Can you hear us?
Yes, we can hear you now.
Okay.
Sorry, I was unmuted.
I sent them a message, but still they're not responding.
Right, looks like that, yeah.
Well, I mean, if they don't come on, I didn't.
Dr. Amit, if you have their cell phone, can
Guys,
you give them a call?
I think they're coming up. I can see some people there, but I don't know.
So I think we need to tell them that they need to unmute themselves.
Yeah, maybe. Wait, can you tell them to unmute?
So have they started their musical night?
Yes, sir. They have actually started with it, sir. I guess that is the
Aditya, the person which is named by Sambit Kundu. I think their screen is still mute.
so we are sending them request to unmute, but they will have to accept.
Yeah, I think if somebody can post it in the WhatsApp group that they need to unmute themselves.
How can we do that?
Unmute.
Maybe in the chat, you know.
I sent them a chat message, Dr. Nanda. Still, they're not responding. I think
they're unmuted now. They are unmuted, I think. Yeah, I can see them unmuted.
So they are unmute, but they are not audible to us. I don't know. At least I can't hear them.
Okay. That's what happens when you don't do dry run. That's the only problem, you know. Guys,
Aditya, were there people audible during the dry run, Aditya?
we did not. They had some technical difficulties with our dry run, unfortunately. So we'll have to just tell them that we cannot hear you, and we'll just have to move ahead. Okay. We cannot hear you. No, I'm just. He's reading my text right now.
Stand behind.
He's reading my text messages. You can post any text message on the group text. See if you can hear.
I wrote down singers, please unmute. So I don't know whether they got it or not. I put the text message there.
Yeah, I know. He said that we are on. I said, I know we cannot hear. That's what I said that.
Right. Yeah. Oh, I see. Okay.
So is it possible? I think he's checking the mobile.
Yes, he is. I'm doing that.
I hope he has got the message.
Yeah, he's got the message. He's got the message.
Yeah.
No. So do you think I should continue the music while they join in?
Yeah, I think that's a good idea.
Yeah, let's just continue. Audio is not set. Okay, I will continue while you set it up.
So one thing what we can do is we can suggest Mr. Bisak to log out and then once again log in.
Yeah, say that again. Sorry, say that again.
So what I request is if Mr. Bisak can log out and once again log in.
Sir, they have already left the meeting, sir. They are not in the meeting, sir.
No, that they're asking me. I have left the meeting, but I'm on the other. I joined. Okay. Okay, I'm going to tell them to log out and log back in. Okay, while we're doing this. Okay. All right. So they are doing it. They are logging out and logging back in. Okay. While they're doing it, I'll just continue with another song. This is a song which everybody likes to dance with this song. जब कोई बात बिगड़ जाए, let's just do that, okay? People kind of somehow love this song, so let us. We can't hear you, so we cannot hear you. They're saying. I'm going to log back in on the main Zoom line. Yeah, let me in. Let me in, okay? Okay, sounds good.
जब कोई बात बिगड़ जाए जब कोई मुश्किल पड़ जाए तुम देना साथ मेरा तो हम न कोई थे न कोई था जिंदगी में तुम्हारे सिवा तुम देना साथ मेरा तो हम Next. ये जी मोहब्बत है ये उनका है काम और महबूब का जो बस लेते हुए ना मर जाए मिट जाए हो जाए बदनाम जाने तो यार हम ना करेंगे प्यार जाने तो यार हम ना करेंगे प्यार Aditya, please send them the actual Zoom link again on the website. Send them the link again. अगर सागर में सागर कोई ले मेरे खुदा दिल से कोई किसी के ना खेले अगर सागर में सागर कोई ले मेरे खुदा दिल से कोई किसी के ना खेले दिल टूट जाए तो क्या हो अंजाम ये जो मोहब्बत है क्यों है हर महबूब का जो बस लेते हुए ना मर जाए मिट जाए हो जाए बदनाम रहने दो छोड़ो जाने दो यार करेंगे प्यार छोड़ो जाने दो यार करेंगे प्यार Aditya, going okay?
I think it's okay.
Okay, let me finish this song. Can they hear me? Vishal, can you hear me? Put a thumbs up if you can. पहली किरणों से सवेरा जागे सूरज की पहली किरणों से आसमां का सवेरा जागे चंदा के किरणों से घरों अंधेरा भागे चंदा के किरण से भूल गए घन अंधेरा मेरे मेरे लंबी सी डगर न चले भी न आंसू भी न बस प्यार की चावले ऐसे गगन के तले. Okay, now we have got the artists who have joined us already, and I hope they can hear me. Vishak and Sanchita, I already had introduced you, but you were not there at that time due to sound difficulties. Now we'll be here. Let me introduce Vishak, my younger brother. We've gotten very close. He came and stayed in our house, calls me Dada, calls my wife Bodhi, and he's almost my musical ambassador for all the Api shows I've done. He's my musical ambassador. And the other thing is other person, and he's actually a Bollywood playback singer and a music director, and was the runner-up in Saregama 2010. He's also a judge at the Saregama Junior Artist Program, which is going to come out. Accompanying him is Sanchita, a name very dear to me for reasons which Vishak will tell you, and she's Saregama Young Junior Idol champion, playback singer, amazing singer. So without further ado, let's welcome Vishak and Sanchita.
We can only hear music, guys. We cannot hear your sound. We should have done the sound check before. Very frustrating. Can you fix that? Aditya, is there anything you can do?
Sir, their setup is not connected to Zoom, sir. Actually, there's a problem with the setup, sir.
Okay, hang on. I think Vishak is calling me, I think. Let me leave this. And
Hello, Amit. Can you hear me, Amit? Amit, can you hear me? Hello?
Sir, he has logged out for a while, sir. I think he's talking to Mr. Bisak.
Chanchal?
Yes, sir.
We may have to, adjourn in about 5 minutes or so. I've had to leave to go to another webinar. So if you don't mind, I've tried to talk to Jags, send him a message. I don't know whether he can hear me. Maybe you or Jags may have to adjourn in about 5-10 minutes. Would that be okay?
It's okay for me, but then will we continue with this musical night, or how do we go do it, sir?
No, I think we just have to, because by 12 o'clock we are supposed to stop this. So, I mean, we are already about past 12. So maybe another 4-5 minutes we can stop it, and because we can't hear very much what they are saying. And let me see if I can
yes, sir. I think regarding that we need to. I think, sir, you need to communicate this to Mr. Amit, because I think they are.
I don't know how to. Yeah, I try to communicate to him, but he's not there now. Let me just see if I can try to get hold of him.
Also, maybe
I don't see him there, in my screen. I don't see him.
No, sir. He has logged out for a while to speak with Mr. Bisak Basu.
Okay. Okay.
Yeah. I think we can communicate through the WhatsApp group with Mr. Johnny has created yesterday. Day before yesterday.
Yeah, I try to commit to Dr. Let me talk to Jag if I can. Jag,
can you hear me? You, Dr.
Yeah, yes. Jag, I have to go for another webinar in 5 minutes. So maybe in another 5-10 minutes we need to stop this. No, anyhow, it was supposed to be stopped at 12. It's already about 12:05. So maybe another 10. Can you do that for me, Jax?
Yes, definitely.
We'll let Amit know that we'll have to stop in 5-10 minutes, and I'm going to leave now. Okay.
So I think Mr. Amit is connecting, sir.
Okay, let me talk to him also. If he's connecting, you can talk to him. Because I have to leave right away because I've got another webinar to go to.
Can you check their sound? They said that their sound is on. Can you check their sound?
It's not working, Dr. Chakravarti.
We can't hear it. We can't hear
it. You remain on the phone.
Okay, Jax, I have to.
Vishak, you remain on the phone. You remain on the phone with me, okay? All right.
You take care. Take care. Jack, take care from me.
I'm going to connect. Aditya, what is your phone number? किसको connect कर सकता हूँ मैं? You can troubleshoot right now over the phone. So we cannot hear you. Can you try your sound again? Let's see you. Aditya, are you there?
Yes, sir.
There is no problem. We are in the same studio. We are going live from the same studio, the same setup, same musician, same artist. Why is the problem? What is the problem? We could not find out exactly.
So that is something which. So Aditya, can you hear me? Unmute yourself. Tell me.
Dr. Amit, Dr. Chakravarti.
Yes.
We have 4 more minutes. We'll conclude this meeting.
Okay, that's fine. Vishak, let's.
Who is the streaming person?
The streaming person, they want to. The meeting is going to be concluded, so forget it, Vishak. After the meeting is concluded, I will talk to you.
Dr. Nanda, you can conclude now if there is no meeting.
We're going to conclude the meeting. Dr. Jags.
Yes,
Dr. Jags. Dr. Jags, I'm going to sing the last song and conclude the meeting. Okay.
Definitely.
All right.
Thank you.
Vishak, you can hang up, and I'll talk to you in just a second. One second.
Don't stop your screen.
Okay, guys, basically what has happened is that I think you guys are destined to hear me only. So it's been a tradition. So I guess that's the way it is supposed to be. So that's the way it is going to be. And can you hear me? Let me just sing this last song, which I always sing my last song. Can you hear me? चलते चलते मेरे ये याद रखना कभी अलविदा ना कहना कभी अलविदा ना कहना होते हंसते हंसियों ही गुनगुनाते रहना कभी अलविदा ना कहना कभी अलविदा ना कहना हमें दिल पर बिछड़ गए कहीं हम और सुनी सी लगे तुम्हें जीवन की ये डगर बिछड़ा हमें दिल पर बिछड़ गए कहीं हम और सुनी सी लगे तुम्हें जीवन की ये डगर हम लौट आएंगे तुम यूं ही बुलाते रहना कभी अलविदा ना कहना कभी अलविदा ना कहना कभी अलविदा ना कहना. Sorry guys, we have tried a very we tried a lot of to get some good Bollywood artists, but due to sound technical problems, sometimes these things happen. We'll do it next time. We'll do a special show just for the Cardiology Association, just for this musical program. Thank you.
Thank you, Dr. Chakravarti.
Okay, you want to give closing remarks?
Dr. Reddy is also on. I will ask him whether he's available.
Hello. Thank you. Thank you very much. Thank you very much, Amit. I appreciate it very much. Can you hear me?
Yes, Dr. Reddy. Go ahead.
I appreciate your program. We enjoyed it thoroughly. I appreciate it very much. The last minute you have come through. I thank everybody for attending this. I'm making it a successful program. I appreciate everyone. Dr. Nanda, Dr. Jags, Dr. Gupta, Shak Sharma, everybody, and the company, and the music group, all the singers. I appreciate it. We'll do it again. We'll do it.
Dr. Reddy, can I interject for 1 second? I want to do this for you guys sometime down the road in a week or two. If you get the Cardiology Association just for a musical evening night for a couple of hours, I'll get the same artist. They'll do it free of cost, no additional charge.
I think not sure Dr. Chakravarti, Dr. Reddy is on or not.
Okay.
Thank you all.
So
I will coordinate that and I'll let you know.
yes, thank you, Dr. Jags. I'm sorry about this technical problem. Anyway, it's a long story. I'll talk to you later. But bottom line here is that we will repeat this. I will come through. We'll make sure that this happens. Okay.
Sure.
Thank you all. Thank you very much.
Appreciate it.
Thank you. Aditya, you can conclude it.
Sure. Chintan?
Okay, we'll do it. We'll have more audience also.
Yeah, Aditya, please hang on. Go into the group text, and we'll just see troubleshoot it once, because we'll do this again in a week or two. So we want to troubleshoot it. So please don't hang up from this meeting, but let's go to the dry run meeting. Okay?
Sure. I'll start that meeting.
Thank you.
Yeah.
Okay. Thank you.
Chintan, please stop the meeting. Thank you.
Okay.